international faculties, respected President, Urological Society of India, Dr. Professor Anand Kumar, Chairman, Indian School of Urology, Professor Rajiv Sood, Co-Chairman, Indian School of Urology, Dr. Arun Chawla, Professor P. Venugopal, past President of Urological Society of India, Professor S.S. Joshi, past President of Urological Society of India, Dr. Asim Shukla, Assistant Secretary, American Urology Association, our expert panelist and international faculty, Paul Mergurian, Chief Division of Urology, Seattle Children's Hospital, Professor Nitin Kekre, President, North Zone Chapter USI, Dr. Lalit Shah, President, West Zone Chapter, Urological Society of India, Dr. Arvind Agarwal, President, East Zone Chapter of Urological Society of India, and Dr. Amlesh Seth, President, North Zone Chapter of Urological Society of India. It's a great day in the chapter of Urological Society of India. After we have started the subspecialty sections of Urological Society of India in the Indian School of Urology, it has taken a great leap forward, especially with the pediatric urology being the flag bearer for the march towards the upliftment of the subspecialty section. As you all have seen, few days back, we had the preliminary round of this pediatric urology competition, and it was a very tough competition wherein the judges were it was very difficult to choose who were the real winners. Now today we have the final round of this competition, and already USI has declared the awards for the winner and the runner-up. But in addition to that, during our last preliminary competition, that is the West Zone round, when Professor Pradap Reddy was around, I had made a request at the end of the competition to Pradap Reddy to see whether he can incorporate an additional scholarship for pediatric urology. It was a great gesture which has come. He has honored my request really, and the Pulli Pradeep Reddy Trust, especially by Professor Pradap Reddy, and the Cincinnati Children's Care Team has come forward with a great gesture that they are going to give an additional scholarship for a month for the faculty mentor of the winning team to visit the Cincinnati Children's Hospital for a month. They will be bearing the whole expenses right from the travel, stay, everything at Cincinnati. And apart from that, they had even requested the AUA to accommodate the candidate for the AUA spring meeting. And this trust again will be bearing the expenses for attending the AUA spring meeting as well. And the USI, it's a great gesture from the Pulli Pradeep Reddy Trust. And the condition for this will go to the faculty mentor of the winning team, provided the mentor is below 45 years of age. If the faculty mentor is above 45 years of age or is not in a position to make a visit in 2021 to Cincinnati Children's Hospital, then his colleague, the urology resident of the winning team, will be given this scholarship. I, on behalf of the Council of Urological Society of India and the Indian School of Urology, extend from the core of our heart the thanks to Pulli Pradeep Reddy Trust, Cincinnati Children's Care Team, and especially Professor Pradap Reddy and Madam Usha for this great gesture extended to a member of the Urological Society of India, which will go a big way in inspiring the young urologists to take up pediatric urology and develop this subspecialty session. So I welcome all the international faculty, all the journal presidents, all senior members from Urological Society of India, and the viewers from USI as well as the SAARC countries for today's final round. And I wish all the team all the very best for their success in this competition. Thank you all once again, and I welcome you again on behalf of USI and Indian School of Urology. Now I would request Professor Anand Kumar, President of USI, to say a few words. Over to you, sir. Sir, unmute, sir. Unmute.
Yeah, good evening to everybody and good morning to our American friends. And we have our senior teacher, Professor Vinu Gopal, Dr. Shyam Joshi, and Dr. Asim Shukla, Dr. Paul Margurian, Dr. Rahul Kapoor, Dr. Rajiv Sood, and Dr. Chawla and TP. I welcome you all for this interzonal final competition in pediatric urology. This is a novel concept and it has taken very well. Everybody has appreciated, everybody has participated. And with young participation, we also learned a lot. And we are also very thankful to our American colleague who have encouraged us and provided the platform, providing the fellowship, and even giving the opportunity to the teachers also to visit the children's hospital and so that they can also learn and also attend the pediatric program in AUA also. So this is a great gesture from our American friends, and we are very thankful to them. And we will hope that our cooperation will continue and more people will get exposure to in American centers and come back and develop this specialty to a higher height. And it is already developing. Few centers have dedicated, and I am sure that next few years more and more people will take it up, and we will soon will be having very good national pediatric urology program and fellowships also. And with this, I would welcome all our panelists and participants, competitors and their teachers to participate in this, and wish them all the best and for this competition. And we know that the winner and runner will get opportunity to go to Children's Hospital. And at the same time, I would like to wish good health to all my USI members, all my American colleagues, their loved ones, their families, and wish them a good health. Stay safe, don't lower your guards. And with this, I welcome you again for this very novel concept and this competition. And again, wishing good luck to all the participants for this competition. Thank you very much. And back to Dr. Raju TP. Unmute yourself.
Rajiv, unmute, Rajiv.
Now, thank you, sir, for your enlightening words. Now I would request Professor Ajit Sood, Chairman, Indian School of Urology, to say a few words. Over to you, sir.
Thank you, Dr. Rajiv. The day we are seeing today is the hard work of last 3 years, and the contributors are in front of you. Dr. Arun Chawla, Dr. Nitin also earlier, and Dr. Rajiv TP, Anant Kumar, all have contributed. What we have done in the era of this COVID era, with the pandemic, what we have achieved is e-academics. E-academics have reached a different height, which is virtual learning or the classes which we were conceptualizing. And one more thing, in the Golden Jubilee year of USI, fortunately, I was the President of Urological Society of India, and a vision statement was released, and we conceptualized cell-based functioning, subspecialty-based functioning of USI. Because we were having in the annual conferences one debate or one topic for discussion, symposia, or some subspecialties, all the 8 subspecialties were not even accommodated. And we decided throughout the year, some activities will be continuing. And I am very happy to see today that with all of you that under Indian School of Urology and dynamism of the society leadership, along with the zonal leadership, we are seeing this day that we are having with the Anil Takwani, the pioneer and the in the forerunner in this concept and making it a reality. The pediatric urology has come a different way in and this is a new normal for Urological Society of India and Indian School of Urology. Now we can say that the way the academics are being organized in this era, they are unparalleled. We are not seeing any parallel throughout the world about what we are doing in India. And the cooperation we are getting in the beginning, we were thinking there are too many webinars, too many e-academics, but now it is the reality, and that we are participating, we are waiting for these seminars, and the students, mentors and experts all on one platform for a subspecialty. This was unimaginable before, and in the conferences also, in one place we were not able to gather everybody, but here anybody from anywhere in the globally or in the SAARC countries or US, everybody can cooperate, coordinate, and be present in these webinars. This competition is a landmark competition which has never happened in, at least in Indian urology. And once we are moving ahead towards the completion, more and more decorations are coming, and which has been shared by our secretary with all of us. And now we see that urology, not only pediatric urology is showing the way to all other subspecialties. We will be doing now wonders in the e-academics. We are giving even e-assessment, assignments we are giving, assessments we are doing, and we are now more organized academically. The teachers are going to be rewarded, mentors are going to be rewarded, students are going to be rewarded. This is a big boost, award rewards which are coming in this way, and too quickly they will change the face of urology globally. At least in India, we are very happy. And I think the same is with the colleagues who are from US joining us. And today, Dr. Ashim Shukla was very enthusiastic when we visited. Dr. Paul is also there. Our past presidents, Dr. Vinu Gopal and Dr. S.S. Joshi are also with us, and many stalwarts like Malkarjun Reddy, Nitin Kekre, and so many. It is difficult to name everybody. So I wish all the best for such activities, and especially pediatric urology, which was everybody thought that it is becoming very difficult to develop pediatric urology in India, and now we see that so much is happening in pediatric urology. It is commendable, and I'm really happy and congratulate Dr. Anil Takmani and also all of us in turn through him. Thank you very much.
Thank you, sir, for your nice and enlightening words. Now I would request Professor Nitin Kekre, President, South Zone Association of Southern Urologists, to say a few words. Over to you, sir.
Thank you very much, Rajiv. It's very nice to see the pediatric urology quiz getting to this platform, and all the efforts behind the scene by the council, present USI Council, to nurture it further. I think we should not forget at this juncture the attempts by the seniors like Professor Venugopal, Dr. Shyam Joshi, who in earlier time also kept the pediatric urology alive. And I'm particularly happy to say that in Vellore, we did our first step. We had a pediatric urology workshop with Cincinnati group coming to us, and from John Hopkins group, pediatric urologists coming to Vellore. And the result is that now we have Chandra, who is heading the subspecialty of pediatric urology. I think quiz is a wonderful way to popularize subject. We did it in Vellore when our first alumni meet happened. We did a urology quiz, and that quiz was picked up at a USI level later on. So I'm really happy that we are doing this. I wish all the participants the best of luck. And
मिलेगी यूएस में
and
सिंसिनाटी
hello,
एक महीने
hello.
ट्रैवल रहना एक्सपेंसेस सब बियर करेंगे वो लोग मैंने कहा सही है
Dr. Sambit, yes, please. Who is Dr. Sambit?
I think
unmute.
somebody's.
Hello, technical assistant. Please mute other.
म्यूट कर
Please.
दिया
Yeah.
सर म्यूट कर रहा हूँ फिर भी मतलब वो ऑन हो रहे हैं
No, I don't know. See, I have not given the list because in
Yes,
your
sir.
list, Dr. Sambit is not there. So later on, give me the identity.
Anyway, I think
You go ahead, sir. Go ahead, sir.
no problem. So I think I will just end my notes saying wishing you all the best and the attempts by the current Anil and all to, and I'm very sure that with the effort like this, the pediatric urology will grow, and hopefully the turf war between pediatric urology and pediatric surgery can be sorted out in the interest of the patient, the pediatric patients, which we need to serve. So with this, wish you all the best. Thank you very much.
Thank you, sir. Thank you very much. Now I would request Dr. Lalit Shah, President, West Zone Chapter, Urological Society of India, to say a few words. Over to you, sir.
Yeah, thank you. Thank you, Rajiv. Good evening, everyone, and good morning to some of them. Rather than taking so much of time repeating what earlier speakers have said, I would wish our West Zone, Dr. Naresh and Dr. Tarun, the best of luck. And just 1% less to hope that the West Zone flag will be kept high. And but it doesn't matter whosoever wins. Ultimate winner is urology, which all of us love. So ultimately, all of us are going to end up as a winner. All the best to you and everyone. Thank you very much.
Thank you, sir. Now I would request Professor Amlesh Seth, President, North Zone Chapter, Urological Society of India, to say a few words. Over to you, sir. Professor Amlesh Seth. I think he's not there.
I checked with him. He told me that probably he's joining, but I think he and Arvind also I have not seen probably.
Now I would request Dr. Asim Shukla, Assistant Secretary, American Urology Association, who is an expert panelist amongst us, to say a few words. Over to you, Asim.
I'm an expert panelist, but I hope I'm not an overused face for you. I feel more, I'm the perfect USI AUA blend. I feel very equally at home in both societies at this point. Thank you to all of you, Dr. Kumar, Dr. Rajiv. I'm not going to go through the names, Dr. Takwani, because but I know that I am in the. I'm in front of the real towering leaders of pediatric urology in India, who, from before I became a pediatric urologist, that I have been following the work of Dr. Venugopal, Dr. Joshi, many others. It's really a privilege to continue to interact like this. It has been one of my great joys as a pediatric urologist and as a champion of pediatric urology to see how the level of this specialty has truly elevated over the 17 years. I think Dr. Kekre was talking about Cincinnati, but don't forget, Dr. Kekre, I came to Vellore in 2001 for a workshop many, many years ago. So for about 17 years, I've been interacting with pediatric urology in India. And to see where pediatric urology is today, not 17, I can't even count, but 19 years where pediatric urology has gone is truly a testament to the work that all of you have done. The academic content, the rigor, the organization, the challenging case scenarios, seeing the residents present, seeing their level of knowledge, seeing the contributions in literature. I know that pediatric urology in India is world-class, as equal as any other society in the world. And for me to be a little part of that will be one of my great joys as I look back, hopefully many years from now. It's a pleasure to be here also with Paul, my cohort. Paul has made, I think, at least 6 trips or 7 trips to India, to Ahmedabad, as part of our pediatric urology bladder exstrophy workshop. He's been a central figure in that work. He took over as Rich Grady came with Rich, and then unfortunately after Rich Grady's loss, he has really filled a void and contributed in a major way. So I'm really pleased that he's with us as well this morning. So again, to all of my USI friends, on behalf of myself personally, the AUA, as a friend of Anil and as a friend of all of you, it's a pleasure to be back.
Thank you, sir. Thank you very much. Now I would request Professor Paul Mergurian to say a few words. Over to you, Professor Paul.
It's one thing I must say, it's extremely impressive what I'm seeing and what I'm hearing right now, because this is really world class. I think the pandemic has actually made us get through this phase of using electronics and virtual conferences to actually do academics, and that's a new way of life, and I think it's a way that's going to probably go on for a very long time in the future and will expand. I'm really excited to be here today. As Dr. Shukla said, I've been coming to India for the past 7 years or so, 6 or 7 years, to Ahmedabad with the bladder exstrophy team. I really enjoy the collaboration. It's very impressive to see how things have changed over the last few years, and specifically when I even talked to Dr. Grady when he used to go there 11 years ago. And there's been a huge change and an improvement in the way things are done in India, especially in bladder exstrophy care. And so you are all part of my team, and I'm glad to be here today.
Thank you, sir. Thank you very much. Now I would request Dr. Anil Tekwani, convener of Pediatric Urology Subspecialty Session, USI, to take over for the further proceedings. Over to you, Anil.
Right. Once again, thank you, Rajiv, for this excellent opportunity to not me only, but the entire Pediatric Urology Committee. And on behalf of entire Pediatric Urology Committee, Subspecialty Committee, I welcome our President of USI, Chairman of ISU, and all mentors and teachers. And on behalf of Indian Pediatric Urology Committee, I extend my warm welcome to one and all present here, specifically my 2 international friends, Dr. Asim Sukla and Dr. Paul. Now, Rajiv, under your dynamic leadership, you have not only given us opportunity, but the support and the guidance, and that is why we are here today. And with that, I would like to introduce my experts, which I have not done any time in these previous 5 events. So quickly, I will introduce the experts. We have a Professor Venugopal, sir, our mentor, and to all knowledge of all, actually, he is the pioneer of web education, or you can say distant education. And I cannot think, I become his student since 2009. He started this web education, or you can say distant education, or e-learning, or you can say that utilizing this internet education in 2005 with this Venuji. It was a Euro Academy, free Euro, this Yahoo group, Venuji, 2005 started. I joined in 2009, and that is how I become a student. So he is the probably now what we are witnessing after 15 years, means 2020, the exponents of this e-learning, which he has actually pioneered in 2005. And because of that, when we begin with this Euro Academy again in last year, we dedicated this Euro Academy to our mentor and teacher, Professor Venugopal and SS Joshi sir. Now, SS Joshi sir, all of you know, a perfectionist by nature, and he pushed us to give our best in academic and clinical field. He didn't like even the one wrong word used. So that much he pushed us, and because of that, we learn a lot. we have a Ganesh Gopal Krishnan. Sir, I met him in 1997 at IKDRC in one of the conference, and I opted for transport and the accommodation committee so I can spend maximum time with these Ganesh. And everyone is the teacher of everyone. Similarly, he's a teacher of mine. And not only that, he's a very charming person and very adorable, lovable, admirable, as always. Even before 1997 and today, you won't see much changes in the Ganesh. He's still similar, equally lovable and admirable. We have a Dr. Asim Sukla, a very good friend of not me, but all weather and all time friend of pediatric urology subspecialty. And he's absolutely right that he's there since last more than 10 years, not only at the Ahmedabad in extrophy epispedias camp, which they are doing since 12 years, but equally he's remained always with the pediatric subspecialty meetings every time in our annual conference as well as in between meetings. He's a division head of minimal invasive at the prestigious Institute of Philadelphia and also professor at the Penn University. So warm welcome, Asim sir. And we have a Professor Paul who is joined from the Seattle Pediatric Hospital, Children's Hospital, and he's also division head there. And he's also endowed chair in the name of Dr. Mitchell in the pediatric urology. So, and he agreed to grace this webinar even in such a short time. And he's also been an extrophy bladder camp in Ahmedabad since many years. And also, I talked to Dr. Douglas Canning and the Pramod Reddy. But they could not make it because of it was really very short notice. But they promised us, and they also contributed into the many of these decision making and intellectual decisions for this meeting. So I also thank to them, and we have our Indian faculties again. Venkatesh is there, popularly known as Venki, a very charming person, very soft spoken, but very strict teacher. And welcome, sir. We have Amilal Bhatt, sir. There is a statement by that hypospadiology is difficult and tiring science. But I have never seen one person who is getting tired of doing hypospadia surgery. That is Professor Amilal Bhatt. So, Bhatt, sir, thank you very much for joining and warm welcome to you. We have a Dr. Ansari, the youngest, say, pediatric urology who become not carved the pediatric urology department from the prestigious institute of SGPGI, but he become a head there. And if I will speak about him, it will take too much of a long time. He's always there, and he's a teacher who do not require such any kind of a preparation. So whenever we contact him to participate, he's always ready to there. And it is really is a student's choice, I can say like that. And the last but not least, the Chandra, once again the youngest master of pediatric urology and the head of pediatric urology department is very prestigious institute of the Vellore. So we have all experts, and I really warm welcome to you. Not taking much of time. Shruti, have you joined? Shruti from the KMC. Hello. Maybe she will join later on. She requested Rajiv last moment that on behalf of resident, she want to express the gratitude towards the USI and USI Council and ISU. So I said that will permit you, but probably she is not joined. So not taking that much other time. Just to inform you that what information I've gathered, that already more than 600 viewers have joined this, and we couple 50 almost are there in this special link, and there is a lot of excitement there. So, and almost viewers from the 10 countries join in this competition, to witness this competition, and not taking too much of time, I invite the first presenter and wishing him all the best. So the first presenter is the Sumit from the Bhubaneswar. So he and his teacher be ready for the sharing the screen. The time for the presentation is 10 minutes. At 9 minutes, they will get the warning alarm, and 8 minutes for discussion. So 7 minutes, they will get the warning. It is request to presenters not to exceed the time, that because that will go very much negative to them with the whatsoever good presentation. So see that you finish well within the time. So Sumit, are you ready?
Yes, sir.
So wishing you all the best. You can start sharing your screen. And during when he's presenting, I request all the experts, all the guests, those who have joined through this special link, to keep themselves mute, so that we can avoid the background noises. So Sumit, share your screen.
Yes, sir. Can you see, sir?
Yeah, perfect. Are you okay?
Yes, sir.
So Sumit is from Bhubaneswar, and he is going to present on the pathophysiology and management of polyuria in posterior urethral valve and long-term follow-up with patient. Your time, Sumit, starts now.
Just a minute, just a minute.
Okay, perfect.
1 minute.
Is it okay?
Okay, sir. I'll start now.
Okay, start.
Good evening, sir, and my dear colleagues. I am Dr. Sumit Agrawal, and my consultant is Dr. Swarnendu Mandal. My topic is discuss pathophysiology and management of polyuria in posterior urethral valve and long-term follow-up. Things we are going to discuss in this presentation would be pathophysiology of polyuria, evolution of valve bladder syndrome in PUV, management, and how we follow up. So obstruction due to posterior urethral valve leads to dilatation of the posterior urethra and bladder with raised intravesical pressures. This further leads to bladder remodeling and also back pressure transmitted to the upper urinary tracts. Polyuria, which is defined as urine output of more than 2 liters per meter square per day, or more than 4 ml per kg per hour, or more than 30 ml per kg per day in children. So polyuria occurs due to 2 causes. One is congenital renal dysplasia, another obstructive uropathy. Renal dysplasia is contributed by genetic and obstructive cause. Obstruction in early phases of renal development promotes apoptosis and increased oxidative stress, which in turn leads to irreversible dysplastic changes in the renal architecture. This is also contributed by TGF-beta-induced renal fibrosis, which further leads to reduced nephron endowment, and this in turn leads to hyperfiltration injury. Obstruction also leads to luminal cell damage in the renal tubules, leading to acquired nephrogenic diabetes insipidus and reduced medullary blood flow due to raised pressure, leading to loss in medullary concentration gradient. This causes impaired renal concentration ability and contributing to polyuria. Polyuria further increases when there is post-catheter diuresis as the child grows with age, and also associated with valve bladder syndrome. So when a bladder attempts to avoid increasing voiding pressures to maintain complete emptying in the compensated phase, there is raised pressure which leads to reflux. This urine is stored in the hydronephrotic kidneys and thus leads to raised post-void residue at the end of micturition. This leads to chronic stretch and bladder remodeling, followed by bladder hypoxia, increase in bladder storage pressures. This pressure is transmitted to renal pelvis, causing renal tubular damage, followed by polyuria due to renal concentrating defect. And this is a vicious cycle which continues even after the valve fulguration. This was first defined in 1982 by Michel and known as valve bladder syndrome. This process is basically due to 3 things, which is polyuria, raised post-void residue, and bladder insensitivity with raised voiding pressures. Bladder remodeling, which occurs in this, occurs due to cyclical pressure increase over a lifetime. So UDS, in infancy and childhood, there is hypertrophy, which is due to detrusor causes detrusor hyperreflexia and poor compliant bladder. In late childhood, it compensates, have an improved compliance. And by adolescence, there is decompensation due to urothelial dysfunction, neuronal degeneration, and smooth muscle tissue degeneration. And there is increased capacity and hypocontractility. So their defective urine concentration is seen in around 60-70% of such boys, and it is severe in around 15% of the cases. Serious consequences are dehydration, which particularly occurs in children who have diarrhea or vomiting, and infants with polyuria, polydipsic, and anorexic. They prefer liquid feeds and difficult to wean and tend to be malnourished because of poor energy intake. Polyuria with poor bladder compliance causes incontinence. And polyuria with poor bladder compliance with raised intravesical pressure leads to back pressure effects and deleterious effects to the kidneys, further leading to more polyuria. Assessment of these children is done by avoiding diary for a week. Electrolytes, if child is very sick, then VBG would be required. Creatinine is done and it is followed up. Ultrasound is done to look for bladder, kidneys, hydronephrosis, and amount of post-void residue. VCUG to look for bladder, any remaining obstruction, and reflux. Video UDS can replace VCUG to look for reflux and also bladder dynamics. DMSA can be done to look for renal scarring and in follow-up. Aims of treatment and follow-up are to maximize renal function, minimize UTI, minimize renal scarring, assess voiding dysfunction, attain urinary continence, assess bladder growth, and assess need for renal replacement therapy and transplant. Treatment is by breaking this vicious cycle causing chronic bladder distension. So for raised post-void residue, we advise patient for timed frequent voiding and double voiding every 2 to 3 hours before the child start getting urge also. If it is not helpful, then clean intermittent catheterization would be taught. If clean intermittent catheterization is difficult, so mitrophenol appendicovesicostomy is done because urethra is quite sensitive in these children. Overnight bladder drainage is instituted if there is persistent hydronephrosis or worsening renal function or recurrent UTI even after the above mentioned modifications, and the continuous bladder drainage achieved by leaving a urinary catheter over a 7 to 10 hours at nights leads to extended period of bladder and renal decompression, and this breaks a vicious cycle of chronic bladder distension. There is some role of desmopressin in polyuria, which was, by a study, it was mentioned that patients who have bladder dysfunction and low basal serum ADH levels, desmopressin might be useful. For if suspected bladder neck hypertrophy, alpha blockers can be used, and it has seen that they can reduce post-void residue up to 70 to 80%. For raised bladder storage pressure, oxybutynin and tolterodine like anticholinergics can be used, and if there is VUR-associated UTI, nighttime chemoprophylaxis can be given, usually amoxicillin, cephalexin, or trimethoprim sulfamethoxazole combination. Regular follow-up post-fulguration is done 3 monthly for 1 year annually, and then annually for 15 years. At regular follow-up, creatinine, so electrolytes, urine routine, in which protein, bacteriuria, and pyuria is seen, ultrasound KUB with PVRU, and uroflow is seen. Cystoscopy and VCUG usually are not done, but although if symptoms are persisting, then we need to do it. And also before labeling a patient with valve bladder syndrome, if hydronephrosis persists. eGFR is calculated at times. Voiding diary is done for a week if hydronephrosis is persisting. DMSA is done if HUN is persisting, and it is done first at 3 months to look for a basal, and then at 1, 3, 5, and 15 years. UDS is done if there is dribbling, reflux, or raised post-void residue. Lifetime prevalence of end-stage renal disease is around 20 to 50%. Age at diagnosis is an unclear predictor, although it is better to diagnose at early and treat. Increased renal dysplasia, recurrent UTI, and bladder dysfunction carries a poor prognosis. Nadir creatinine during 1 year of life, if it is less than 0.8, it is a minimal risk, although more than 1.2 carries a higher risk. Lower eGFR has a worse risk, and SWRD score high is a worse risk. SWRD score is an objective criteria for prognosis, which is the shape of the bladder, trabulations of the bladder wall, presence of reflux, and presence of bladder diverticulum. So these were 2 studies done in 2017 and 19, which was undertaken to demonstrate that the reliability and reproducibility of SWRD score. It showed that more the SWRD score, worse is the prognosis. So we can see in the diagram SWRD score 0 and SWRD score 7. I would like to discuss a case. A term male born with a post-urethral valve, he underwent catheterization by a 6 French feeding tube and was stabilized. At day 7, there was reduction in hydronephrosis and creatinine fell down from 2 to 0.7. endoscopic valve ablation was done, followed by which he was kept on regular 3-monthly follow-up for a year. At 1 year follow-up, he was doing well. And then 2 year also he was doing well. And at 3 years, he was doing well, a creatinine of 0.8. At 5 years, at 4 years, he did not come up. And at 5 years, he came with increased frequency, not gaining urinary continence and nocturnal bedwetting. Evaluation showed polyuria, bilateral hydronephrosis, PVR of around 100 ml, grade 3 VUR, raised creatinine and compliant bladder. He was admitted, catheterized, stabilized, after which he was advised for his changing in voiding habits. And also tamsulosin and tauteridone were advised. On then he was kept on follow-up 3-monthly up to 6 years of age, and then at 7 years of age, on his last follow-up, he is doing well and is on periodic follow-up. So there are some points to be remembered. Parenteral counseling is very important in this. For a case of posterolateral valve with polyuria, safe storage at lower intravesical pressures with adequate bladder drainage is important to break the vicious cycle and control complications of further renal damage and polyuria, bladder dysfunction, and progression to end-stage renal disease. Periodic follow-up and correct intervention at appropriate time is key to success after valve ablation. Renal transplant might be needed in the cases who has end-stage renal disease, and the results of renal transplant are almost similar to non-uropathic group patients. I would like to conclude my presentation by saying that although an endoscopic ablation or urinary diversion will address uropathy due to posterolateral valve at birth, but the embryologic insult causing bladder dysfunction and polyuria is profound and requires these infant boys to remain under the extended care by a team of urologists, nephrologists, pediatricians, and at least till adolescence, and also continue in the adult period if needed. Thank you.
Thank you, Sumit. You can now stop sharing the screen. There is some background. Kruti, can you do something for this?
Sir, I have muted everybody.
Okay, perfect. Thank you. So thank you, Sumit, and his teacher, Dr. Sarvendu. And this is just to inform the experts that the right time intervention by the teacher is not going to go against the outcome of this that particular student's performance. So because the format of this competition is there, that is a two student teachers competition together, right? So teachers are equally able to participate without damaging the outcome of students' presentation or performance. So thank you, Sumit, and let us start the question and answer. So count the time from right now, and I request our own Dr. Prasanna, this subject is very close to his heart, to ask the first question. Prasanna, go ahead.
Yeah. Thank you, Dr. Sumit. It was a wonderful presentation. So I have a question for you. See, we are dealing with the syndrome of nocturnal overdistension of the bladder, otherwise called as SNOB. And the treatment for that is actually what is called as NBE, or Nocturnal Bladder Emptying Program, right? So which do you think is the single most effective nocturnal bladder emptying program strategy in these children? Single most effective, just name one.
Overnight catheter drainage.
Yeah, that's good. The second question that I had is, in your presentation, you have put it that, you will follow up this child for 3 months for the first year and then annually. Do you think that is a good strategy?
Yes, sir.
Okay, the answer should be for that is that for posterior urethral valve children, there is no fixed.
Prasanna, preferably don't share the.
Okay. The last question is, can you answer to me what is pseudo residue and how does this, how do you need to treat children who have that?
Okay. So pseudo residual urine occurs due to if there is functional if we examine, there is no reflux. If we fill the bladder, we will find there is no reflux, and this reflux does not occur because during distension, the urethral orifices gets closed by the detrusor. Although this amount, when patient voids at the end of micturition, the amount of urine stored in the hydronephrotic system comes to the bladder, leading to raised post-void residue. Because this becomes a pseudo type. Because as we did not find any reflux, and at the end of micturition, the amount of urine stored also comes in the bladder. So this is a pseudo type of residual urine volume.
Right.
And
okay,
we
so
can treat it by asking the patient
Anil. Right. So
double voiding.
Okay, perfect.
Double voiding or triple voiding would be helpful in this.
Okay, perfect. You complete your answer?
Yes, sir.
Yeah. Okay. So we go to the next expert, Professor Paul. Would you like to ask question? You unmute yourself, sir.
Yes, Sumit, I really enjoyed your talk. One of the things that you talked about is mostly treatment in older kids, where you can actually give them fluids and supplements. You haven't talked about the management of polyuria in an infant, so in an infant child. The second question I have for that, also related to that, is the use of oxybutynin, and what do you think is the advantage of using oxybutynin right from the start, right from birth after valve ablation, rather than waiting until the bladder decompress or the compliance gets worse over time?
So it is seen that giving oxybutynin relaxes the bladder, and this also reduces progression and effect of hypoxia over the detrusor bladder wall, and also reduces the bladder remodeling. Thus, if we give it, it has a good effect in preventing renal remodeling, and thus reducing the chances of valve bladder syndrome and further degeneration to myogenic failure also.
And what about the management
first question
of an infant with polyuria or concentrating defect?
We need to give them, we'll have to feed them with milk and fluids, possible what we can give.
Let me place this question again. Is that you have put the feeding tube, right? When you see the patient of PUV on second or third day or first day, what worries you, and why, if there is a dehydration, how it can be explained, and how will you manage?
So it occurs because of diuresis.
What is the exact cause of diuresis?
It is post-obstructive diuresis.
Okay.
Which occurs in these patients. They might give a lot of urine output. So in these if there's a lot of urine output, we'll have to replace them with IV fluids, because sometimes it can be just polyuria for 1 to 2 liters, and sometimes they can also be up to 3 liters, 4 liters also they can pass. For them, if they are getting dehydrated, we'll have to replace IV fluids. And also if they are not taking, then we can give by RT feeds.
Dr. Paul, you would like to add anything in our question, or it's okay?
No, I think it's okay. I think the important thing with infants is that they can't tell you that they're thirsty, right? And they can't tell you that they're salt depleted. So you have to think about supplementation. I think your last statement is the work with nephrologists, really working with nephrologists to maximize the care of these patients is really important. I mean, we cannot, as urologists, take care of them solely ourselves. So you have to involve the nephrologist right from the start.
The next is the Asim. You can go ahead with your question, Asim.
Yes, Sumit, that was a wonderful presentation. Visually stunning, very nicely, great graphics and animation. So well done, very visually attractive, and also good content. The question I would have, you had talked about a scale where you looked at reflux, diverticula, various different factors that can predict outcomes. Which one to you is the most important outcome? Which single study is the best predictor for renal outcome?
Renal dysplasia.
Which laboratory value or radiological exam, or if you had one thing you could ask for to predict long-term renal outcome, what would you ask for?
It is to look for renal dysplasia, and this renal dysplasia perfectly we can say only by doing a histopathology, but ultrasound works very for it, because there will be hyperechogenic kidney compared to the liver. There will be loss of corticomedullary differentiation, and there can be cysts in the kidney also, and improperly placed calluses can also be there. So this is renal dysplasia, I would like to say as an answer.
Is there a laboratory value you might obtain?
Laboratory values. The creatinine.
Good. That's what I wanted to get at.
Okay. Yeah. Go ahead.
Yeah. Sorry.
Yeah. Go ahead.
Okay. Do I want time? I want to be careful about time. There are many people speaking.
Yeah. So
why don't I let others ask questions?
Yeah. Yeah. Dr. Ansari, go ahead. Unmute yourself, sir.
Yes, Dr. Sumit, we cannot manage polyuria unless we differentiate between polyuria and diuresis. You just tell me two main difference between polyuria and diuresis. What is what?
Polyuria
and diuresis. What is what?
It is post-obstructive diuresis which occurs, and polyuria is occurring all the time. After relief of obstruction, if something occurs, that is diuresis, and if it is occurring all the time, then it is polyuria. And also,
what is the basic difference between the two?
Time up.
Pass the question.
Okay. Kruti, it's a 7 minute or 8 minutes completed?
8 minutes completed.
Okay, you should have given a warning. Okay, perfect. Sumit, with that, your time is up. Thank you very much once again to you and your teacher for this presentation. And with that, I request experts to not to make much of the comments related to the presentation. The reason is that they can get the one more question, and second thing is that the judges do not want other comments other than the questions. So please take care of that thing. And before we move to the second presentation, we have to give some time to judges to mark the score. And then that time to utilize, I would like to ask Asim. Asim, when I came in Philadelphia in 2018, there was a Robo Week. So can you tell us something in very brief, your journey in a robotic in pediatric urology, and what exactly the Robo Week, and how our people can join if they want to join sometime in future?
Oh, yeah, no, just stay in touch with me. You know, I don't have the fellowship like Pramod has for international fellows, but I am very open to hosting any of the trainees, my colleagues. You're more than welcome to come to Philadelphia. Once a year, we do hold a robotic surgery workshop. And what we do is we basically consolidate some interesting cases. So, for example, typically during that week, you might have a robotic Mitrofanov, a ureterostomy for a duplex system, redo pyeloplasty, ureterochalacostomy, things like that. So it's a 1 week of all we do is robotic surgery. We have a lot of time to talk and challenge each other. And we do 1 half day in the laboratory to practice on the robotic console. So I, certainly email me. And this year, of course, it's canceled because of the COVID situation, but hope to reopen it again next year for 2020.
Generally it falls before the conference, I think, AUA meeting.
Yeah, exactly. I try to do it 1 week before the AUA. So, to make it easier for those of you who are traveling to come.
Why I ask this, that many of the youngsters are watching this webinar or public competition, and they would like to come at this your place, so they can get the advantage of this information.
Yes, absolutely, and many people have, and more than welcome.
Thank you. So we move to the second presentation, and when it comes to the question and answer, for each expert, please ask not more than 2 questions at a time. So we request the second presenter to be on this screen. This is Dr. Samarth Patel, and his mentor is Dr. Siddharth Yadav, and they are presenting on continuous antibiotic prophylaxis in VOR current concepts. So, Samarth, are you ready? You are ready?
Yes, am I audible?
Okay. Yeah, you are audible. You happy?
Shall I start? Yes,
Yeah,
sir,
you
I'm
can
fine.
start. Your time starts now.
Okay. Good evening, everyone. Respected teachers, seniors, and colleagues. At the outset, I would like to thank the USI, ISU, and the pediatric urology team for this wonderful opportunity. The topic allotted to me today is current concepts of continuous antibiotic prophylaxis in VOR. So, vascular reflux is in itself not a problem. However, it has the potential to cause recurrent pyelonephritis and secondary long-term clinical consequences of renal scarring, including chronic kidney disease, hypertension, and complications of pregnancy. It was hypothesized in 1960 that sterile urine could scar the kidney, but only in the face of prolonged elevated intravascular pressures by its hydrodynamic pressure. This was called as the water hammer effect proposed by Hodgson et al. However, no such clinical entity has been predictably demonstrated, and currently it is considered that sterile reflux is benign. So then how does VOR actually cause renal damage? The real cause is UTI. Lower tract infections themselves do not cause a renal parenchymal damage, but can lower the threshold of reflux and mechanically deliver the bacteria to the upper tract, hence promoting renal damage. So the infected urine in a refluxing system leads to pyelonephritis, which further causes focal ischemia, interstitial damage, and fibrosis, and has the potential to cause irreversible renal scarring, termed as reflux nephropathy. The principles of management in VOR are mainly threefold. The first being prevention of UTI, prevention of renal scarring, and preservation of renal function, and minimize the morbidity of treatment and follow-up. Historically, children with any degree of VOR were thought to be under significant risk of long-term sequelae, and they underwent definitive surgical intervention with ureteroneocystostomy. Later, this notion was challenged by Lenigan et al., and intermittent antibiotics were given to treat infections, and it was seen that spontaneous resolution of reflux was seen in follow-up in up to 43% of cases. We know that the natural history of VOR is such that majority of VOR resolves spontaneously. The bladder dynamic stabilizes and the uretrovesical junction remodels as the intramural ureter progressively elongates with bladder growth over time. However, only up to 1/3 or even less of high-grade refluxes resolve spontaneously over time. The rationale of use of continuous antibiotic prophylaxis in VOR is based on the Big Bang concept, which states that it is the first febrile UTI in the presence of reflux that has the greatest propensity to cause a clinical significant post-infection renal scarring. And following the first infection, around 10 to 30% of the children will develop at least one recurrent UTI. So the rationale on which CAP is based is that sterile urine does not damage the kidneys and spontaneous resolution is expected in majority of the children. In the first 2 months of life, amoxicillin and trimethoprim are the preferred antibiotics which are given. And once the child is of 2 months of age, the most commonly used antibiotic is trimethoprim sulfamethoxazole. Nitrofurantoin is another alternative in this age group. These antibiotics are usually given at 1/3 of the therapeutic dose as a single nighttime dosing to take advantage of the nightly physiological retention of urine. The previous practice, which was merely based on grade of reflux and age of the patient, was challenged by RIVER trial published in 2014 and its reanalysis. RIVER stands for Randomized Intervention for the Management of Vascular Reflux Study. It was designed to evaluate effectiveness of antimicrobial prophylaxis in children who have grade 1 to grade 4 reflux after an initial UTI. They were randomized to receive either oral trimethoprim sulfamethoxazole or an oral placebo. Those receiving antibiotics had a 50% reduction in recurrent UTI rates. This effect was even more robust in those who were presenting with febrile UTI, showing 60% reduction, and those with gallbladder dysfunction at baseline, showing 80% reduction. However, in this study, the renal scarring appeared unaffected. Hence, the primary goal of antibiotic prophylaxis, which was preventing renal parenchymal damage, was not achieved by antibiotic prophylaxis according to this study. These negative findings of RIVER trial were further augmented by the fact that long-term antibiotic prophylaxis itself has many associated problems. There is nearly 24-fold increase in the prevalence of resistant strains. Around 2/3 of breakthrough UTI in the antibiotic arm in RIVER trial were antibiotic resistant. And breakthrough UTIs in these children receiving antibiotic prophylaxis are not just merely singularly resistant to the treated antimicrobial. Instead, they present as multi-drug resistant infections, which is serious and difficult to treat. Other problems which are associated with long-term antimicrobial prophylaxis are its impact on the microbiota, leading to Clostridium difficile associated diarrhea and increased susceptibility to salmonellosis, increased adiposity. There are also suggestions of possible association with IBD and asthma. Keeping in mind all these concerns associated with prophylaxis, and the question which really arises here is that can we really take the risk to completely omit antibiotic prophylaxis? There, the answer of this lies in risk stratification of VOR, a concept which was introduced and confirmed by reanalysis of RIVER trial by Wang et al., which showed that recurrent UTI in a group with uncircumcised males, females, high-grade reflux, and with the presence of gallbladder dysfunction or constipation is 3 times higher as compared to the rest of the group, and the number needed to treat for this subgroup is 5 as compared to 18. So this study confirmed the benefit of antibiotic prophylaxis for high-risk groups and questioned its value in low-risk groups. I also like to add that it is also considered that the reason why RIVER trial could not show significant benefit of antibiotic prophylaxis to reduce the renal scars was due to the underpowered nature of the study, and also that the study group included around 91% of low-grade reflux cases. Hidas et al. Divided children with VOR into various groups based on the presence of risk factors. The low risk factors including male gender, age over 5 years, Afro-American race, unilateral reflux, lower grades of reflux, and the absence of gallbladder dysfunction or scars, and presenting as antenatal hydronephrosis. High risk features include female gender, under 1 year of age, Caucasian race, bilaterality of the reflux, grade 3 to grade 5 reflux, presence of gallbladder dysfunction or scar, and those presenting with multiple febrile UTI. He divided these children into 3 groups: low risk group, intermediate risk group, and high risk group. And the 2-year risk of breakthrough UTI in these groups were 8.6%, 26%, and 62.5% respectively. Now that we know the risk factors which guide treatment, let's go to the next pertinent question: is when to start antibiotic prophylaxis. For every hour antimicrobial therapy was delayed in treating febrile UTI, the odds of new renal scarring was increased by 0.8%. So antibiotics should be started as soon as possible. Odds of developing a renal scar doubled if antibiotic prophylaxis was begun after 72 hours as compared to within 48 hours. It is necessary that children started on antibiotic prophylaxis are adequately followed up with annual general evaluation, including blood measurements, blood pressure measurements, ultrasound, KUB, a urine analysis for proteinuria. Voiding cystoethiogram or a radionuclide study should be done 12 to 24 monthly or a per case basis scenario. DMSA should be done when ultrasound is abnormal, when there is great concern for scarring. If the child is asymptomatic, there is no need to repeat urine cultures. However, in case of any unaccounted for febrile episodes, urine culture and sensitivity should be done. Antibiotic should be stopped when it has served its purpose, like in the case of spontaneous resolution of reflux or downgrading to a low-grade reflux in older children more than 5 years with normal kidneys, as the child progresses beyond the toilet-trained years and after certain risk factors like gallbladder dysfunction or phimosis have been eliminated, or when it has failed its purpose and we are compelled to switch over to alternate therapy, like in case of persistent reflux, febrile UTI, worsening parenchyma, or new scars and non-compliance with medical therapy. So to summarize, based on current evidence, in first year of life, those who are not toilet trained, an antibiotic prophylaxis is recommended, especially for children with history of febrile UTI or high-grade refluxes, and for patients with lower urinary tract dysfunction or bowel dysfunction and renal cortical abnormalities or recurrent febrile UTIs in toilet trained age groups. In view of the limited benefits, potential new approaches are being researched, like cranberry and probiotics, which are still under investigation. So to conclude, I'd like to say that individualized treatment for VOR is now the practice, and antibiotic prophylaxis is associated and its associated risk may be an overkill in low risk group, while it may be over adventurous to omit antibiotic prophylaxis in the high risk group patients. Thank you.
Thank you, Samarth, for your presentation, and also Dr. Siddharth, his mentor. So you are ready?
Yes, sir.
Okay, so this subject is very close to my heart as well as of Asim Sukla. Thank you for this presentation, and let me ask the first question. That patients with the past history of pyelonephritis and the scarring, right, they are at high risk of breakthrough infection, even if you have kept patient on antibiotic prophylaxis. Why they are prone to breakthrough infection as well as risk further scarring or new scar?
So can you repeat the question? Your voice was breaking a little.
See, am I audible now? See,
Yes, sir, yes, sir.
as you know that the previous pyelonephritis caused scar patient, scar kidney are more susceptible for they are considered a high risk. The reason is that they have more chances of breakthrough infection, either extension of the scar, previous existing scar, or new scar formation. Why it is so?
So these group of patients usually have abnormalities or usually are associated with high grade refluxes per se, and the indication that they have developed scars is that the pyelonephritis which developed was because of a significant reflux, and there is a propensity for new scar formation which may appear at a later stage as well. So
any role of bacterial characteristic or host characteristic? Those who have many patients develop pyelonephritis. Couple of patients develop the scar, couple do not. Why it is so? And if they have developed the scar, are they prone to develop a further scar or breakthrough infection because of scar? Breakthrough infection scar, and why? It's okay. Now let us go to the Asim. It is very close to, this subject is very close to your heart. You can ask one or two questions.
Okay, thank you, Anil bhai. Samarth, I wanted to ask, if you have a 4-year-old girl who's had 2 breakthrough urinary tract infections on trimethoprim sulfamethoxazole and also on nitrofurantoin. So you've had 2 breakthrough infections. The child has bilateral grade 3 reflux. She's 3 years old. If the family, when you're counseling the family, what do you tell them that surgery will achieve? You will get rid of the reflux. What benefit will getting rid of reflux have in terms of urinary tract infections, in terms of scarring? What more, how can you improve that child's life by doing surgery?
So I'd like to counsel the patient and his family, her family, regarding that. Females are per se more susceptible to infections because of the shorter urethral length. And if performing surgery, what happens is that we are treating reflux, whereas with antibiotics, we are just keeping the urine sterile. So if we perform surgery in this case, it ensures that the upper tract is preserved from further damage because there is lesser risk of upper tract bacteria in these cases.
Can you give me an estimate of what is the chance? Do you eliminate febrile urinary tract infections? What's the risk of recurrent febrile UTI, even if you successfully get rid of the reflux?
So it has been documented by various studies that breakthrough infections are prevented. However, the presence of new scars might not be certainly said by any surgeon that they can be prevented by surgery or by antibiotic prophylaxis or that, but it definitely reduces the risk of recurrent infections.
Okay, so we move to the Ganesh sir. Ganesh, Dr. Ganesh, would you like to ask question? Ganesh sir. Okay, Venkatesh. Unmute sir. Venkatesh sir, unmute yourself.
Yeah. Thank you, Dr. Samarth. I want to know the rationale of antibiotic prophylaxis being given at night is that the 1/3 dose that you said dwells in the bladder and therefore it is sufficient. You said the first few months of life you will give antibiotic prophylaxis at night. What is the rationale? Because this child keeps emptying its bladder every half an hour or so, or 1 hour. What is the rationale of this prophylaxis? How does it work?
So the rationale of prophylaxis is to keep the urine sterile. Since nighttime is the best time in which there is physiological retention of the urine and the concentration of antibiotics in the urine can take place. Hence, it is considered best to give it as a single dosing at nighttime.
No, probably didn't listen to me. These children keep emptying. It's an automatic bladder. In a neonate, an infant, it keeps emptying. There is no dwell time at night in this bladder. So do you think it really is sufficient to give only at night?
So whatever chance is of retention is there, it is maximum to be at the night time when the child is sleeping. So I think that would be the best time to give the prophylaxis.
Okay. You treated a child, you said when you will start antibiotics, when will you stop antibiotics? What are your criteria to stop prophylaxis?
I'd like to divide the answer into 2 phases. One is when the antibiotic prophylaxis fails to control breakthrough infections, or in which there is new development of new scars, or the renal parenchyma is worsening on follow-up, or the patient or parents are not compliant, in those cases, I'd like to switch over to a better therapy or an alternate therapy. And in cases in which there is spontaneous resolution of the reflux on follow-up, or the reflux is converted into a low-grade reflux, especially in older children, or in cases where the cause has been associated to be lower urinary tract dysfunction, and that has been addressed to, and the reflux downgrades to a lower grade. In those cases, we can stop antibiotic prophylaxis. All the while counseling the parents that still there is a risk of infection, and in any case of a febrile UTI or similar symptoms, they have to follow up and come back to the hospital.
Okay, Dr. S.S. Joshi, sir, unmute yourself, sir. Joshi, sir, you can ask your question.
It is recorded that even if you operate on the reflux, it doesn't prevent the scar.
Yes, sir.
How is that?
So scarring is actually, it is very controversial to comment on scarring, because scars develop at a later stage. Even if the infection has taken place at an index time, the development of scars might take variable duration depending upon the age and various other factors. And the scars which have presented at later age.
Can't hear you.
Can you hear me now?
Sir,
I can't hear him.
No, sir. Sir, we all are clearly listening. Is clearly audible to all of us. Is there any problem with your system? See, this time is not going to count, Samarth, from your total time, right? Okay. So don't worry, right? Sir, am I audible to you?
Hello.
Joshi, sir, am I audible to you? Hello. So there is some problem with your audio system, sir. Okay. So we move to the another question, and let me ask one more question. That Samarth, your patient is on antibiotic prophylaxis, and is doing perfectly well. Will you consider doing VCUG anytime? And if you are considering, what are your indications?
On follow-up, I would
Should
like
we do or not?
Can't hear you.
Sir, coming back to you, sir. Sir, please. Can someone, yeah, please go ahead.
Yes, sir. So I would like to do VCUG to document whether there is persistence of high-grade reflux or there is a downgrading of the reflux in these cases. And I'd like to do so at a 12 monthly to 24 monthly basis.
You made a statement that reflux is not a harmful thing, right? Why you want to see again and again that whether the reflux is downgrade or not? Child is doing perfectly well. Why you want to add 1, 2, 3 VCUG at particular intervals? Don't you think that it is much harming than the even surgical intervention, multiple VCUG, which involves the trauma as well as the radiation?
I can do it in a low dose and a fluoroscopy, or I can opt for a radionuclide scan as well. But I'd still like to do cystogram in these cases to document whether it
child is doing perfectly well. Child has reached to the toilet train. You have addressed the BBD if there, and you are stopped antibiotic prophylaxis. Child is still doing well. Why you still want to do VCUG? For what reason?
If we have stopped the antibiotic prophylaxis, he is out of the red flag zones in which he's already toilet trained, and he has moved to an older age. In those cases, I'd not like to repeat an investigation. I'd like to just call him out for follow-up and to ask for any symptoms.
Okay. So we take we'll take a last question from Paul. Paul, you can ask your question.
So I totally agree with you. I think if you're going to do a study, just think about, is that study going to change my management? So getting VCUGs on a yearly basis for reflux is most likely not the right thing. I'd like to ask you a question. If you, for example, have a newborn with antenatal hydronephrosis that has grade 5 reflux, male child is circumcised, and then you put them on prophylaxis. 3 months later, you get an ultrasound. The ultrasound shows the hydronephrosis has resolved. There's no hydroureter. How would you counsel them regarding antibiotic prophylaxis and continue with antibiotic prophylaxis at that point?
So all the factors which you mentioned in this index case, that is a male child who is circumcised and diagnosed on antenatal hydronephrosis, falls into a low risk category, and there is a very low risk of breakthrough UTI in these kids. And primarily, I would not like to place such a child into further antibiotic prophylaxis, and just counsel the patient that the parents of the patient, of the child, that he might develop any recurrent infection or might develop fever in the follow-up, and only in this situation we'd like to further diagnose or investigate him further, and I would not like to prescribe any further antibiotics in this case.
Would you get a cystogram on him to confirm resolution or presence of reflux? at any point?
No, sir.
Okay. The other thing to consider is a contrast enhanced body ultrasonography. So that's a new way of doing it and reduces the radiation dose.
Yes, sir.
Okay, so I think Kruti's time is up.
Yes, sir.
Time. Okay, fine. Thank you, Samarth, and his teacher, Dr. Sridhar. They were from Delhi, and thank you very much for your presentation and the question and answers. So we give some time to the judges to mark the score, and during that time, Paul, I would like to ask about that your journey in the pediatric urology, in the field of pediatric urology. Brief means when you decided to join, means work for the pediatric urology, and why?
So I initially was right through medical school interested in pediatric and interested in pediatric surgery. So I started off as a pediatric surgery person. So I was just started in general surgery, wanting to become a pediatric surgeon. Then I met my mentor at the University of Rochester, Dr. Ron Rabinovich, who got me really interested in pediatric urology. That's when I decided to switch from general surgery to urology and to pediatric urology, and I have not regretted it since. I did my fellowship at the Hospital for Sick Kids in Toronto and worked in Toronto for a while with Dr. Tony Curry, who's a big proponent of the risk stratification of vesicourethral reflux. And have been at Dartmouth College for over 15 years before joining Seattle Children's as the chief of pediatric urology at Children's for the past 10 years. I had the privilege of working with Dr. Grady for a few years before he became ill and passed. I carry a huge legacy at Seattle Children's, especially with Dr. Mitchell and Dr. Grady's background there. And try to hope to develop that program into one that's a class program based on the history of that division.
Okay. So do you have any international fellowship program? And how our student can apply? Yeah.
We've created a Rich Grady Fund. So there's a fund that's in the name of Dr. Grady that is specifically for international people. So anyone who would like to come as an observer to our institution can apply, can actually contact me. And we have a fund available. We would be able to provide funding for at least a month of observation at our institution. Including if they were interested in doing some clinical work and clinical research. That's something that we would foster.
Thank you very much for that information. And I think it is great information to our junior urologists as well as the students who are interested in the pediatric urology. So with that, we move on to the third presentation. Amit Kumar, are you ready with Amit? You are ready with your presentation? So
yes,
we
sir.
have now next presentation is from Team Trivandrum. It's Dr. Amit Kumar and his teacher is Manoj Kumar. You can share your screen and their subject is the topic is the prenatal and postnatal PUJ like obstruction or PUJ obstruction like hydronephrosis, investigations protocol and management algorithms. So he's talking on the hydronephrosis, but mind well that it's a PUJ obstruction like hydronephrosis, investigations protocol and management algorithm. So are you okay?
Yeah, I'm okay, sir.
Amit?
Ready to start.
There is some problem with your audio. Can you repeat your sentence? You okay?
Sir, you're able to see, sir? Hello?
No, do you have a two system kept?
No,
there?
sir. No, sir. Single system is there, sir.
Kruti, can you help him? Where is the problem? Why there is some echoing? Hello?
Yes,
sir,
is it okay now?
Okay, okay.
Thank you. Shall I start, sir?
But you are in, yeah, you have to be. Okay, you start your presentation now.
Okay. Good evening, all. At the outset, I'd like to thank USI for giving us an opportunity to showcase in front of all the stalwarts of urology. Myself, Dr. Amit, and I'm from the Government Medical College in Trivandrum. And today I'll be presenting on investigation protocol and management algorithm of PUJ obstruction like hydronephrosis in the prenatal and postnatal period. I don't have any conflicts of interest to start with. I'll be covering the topic under antenatal hydronephrosis and postnatal hydronephrosis and concentrating on the evaluation management protocol of each one of them separately. Coming to the antenatal hydronephrosis, it is twice as common in males and 20 to 40% are bilateral. There are various causes, including transient hydronephrosis, which constitutes approximately 41 to 88%, and PUJ obstruction constituting 10 to 30%. However, of the all causes, I'll be concentrating today on pelvic junction obstruction as the topic restricts me to the same. How is the antenatal hydronephrosis measured? It is measured using an ultrasound in the transverse plane at the level of the renal sinus or the renal hilum, and which forms the main basis for classification of antenatal hydronephrosis. And it classifies hydronephrosis into mild, moderate, and severe, with APD in the second trimester more than 10 mm constituting severe, and in the third trimester more than 15 mm constituting the severe category. There is SFU grading system which takes into account the renal parenchyma, and the parenchymal compromise constitutes the fourth grade of the SFU classification system. The UTT classification is the latest one, which includes the lower urinary tract into consideration, like the ureter, bladder, and the unexplained oligohydramnios, along with the parenchymal thickness and the parenchymal appearance. Prenatally detected severe unilateral newborn hydronephrosis is a relatively benign process that can and should be safely followed up non-operatively. This was adequately told by Koch in 2000. But if this is the case, if all of them resolve, then what is the need of classification? The need is because to prevent further damage to the kidney, avoid excess trauma of investigations, patient counseling and reassurance, and select the patients who would benefit from early surgical intervention. Coming to the antenatal ultrasound, what are we actually looking at? We are looking at the laterality, unilateral or bilateral, severity of dilatation, echogenicity of the kidney. Along with that, we look for the ureter, we look for the bladder and the sex of the child and the amniotic fluid volume. Coming to the prenatal evaluation, the first scan is at 18 to 20 weeks. And according to the scan, we grade the system into low risk and increased risk. With second trimester scan, 4 to 7 mm and more than 7 mm constituting the low risk and increased risk. Whereas third trimester, the APD more than 7 to 10 mm and more than 10 mm constituting the low risk and increased risk respectively. However, the increased risk, any of the other UTD parameters are abnormal, that also constitute the patient into the increased risk category. Now, after categorizing the patient, how do we follow up? The patient with low risk, we do an additional ultrasound at 32 weeks, and after birth, a scan is repeated in the first week and at 1 to 6 months later. And in case the patient is in increased risk category, we place the patient under stringent follow-up, doing the ultrasound every 4 to 6 weeks. And the scan is repeated again after birth in the first week and at 1 month of age. Now, what in case of bilateral hydronephrosis? The cases with bilateral hydronephrosis, specifically PUJ-like obstruction, we keep them also under follow-up. However, if severe bilateral hydronephrosis is associated with oligohydramnios, the only change is that we do a postnatal scan within 48 hours. And intervention is reserved only for patients with lower urinary tract obstruction, and solitary upper PUJ-like obstruction does not need intervention in the prenatal period. The same patient is followed up in the postnatal period. The first scan is done at 5 to 7 days postnatally because of the dehydrated status of the patient within the first 48 hours. The ultrasound probe is used as 5 to 10 Hertz probe as compared to the 3 to 5 Hertz used in the adults. Now, each part of the urinary tract is evaluated separately. We start with the bladder and going on to the lower ureter, the upper ureter if visible, and the kidneys. Now, in the bladder, we see for the, in case the bladder is full, we see the hydronephrosis in full and empty bladder and see the change which happens after emptying. We see the severity and the level of obstruction if we are able to make out. And as far as the kidney is concerned, kidney is visualized in the transverse and sagittal plane in the supine and prone position. And for the upper pole of the kidney, the liver or spleen can be used as a window for acoustic window. Now, when do we do an early scan? As already highlighted, early scan within 48 hours is done in case of severe bilateral hydronephrosis in the solitary kidney, or in the presence of oligohydramnios. Now, adjuncts to ultrasound like pulse Doppler ultrasound and color Doppler ultrasound can help to differentiate obstructive from non-obstructive hydronephrosis, in which we are looking at the resistive index and the ureteric jets. They are just suggested changes and they are not confirmatory. Now, depending on the APD diameter in the postnatal scan, we classify the patients into low, intermediate, and high risk. Now, patients with APD diameter between 10 to 15 or associated with central calcium dilatation fall under the low risk category. In the intermediate risk, any patient with diameter 15 to 20 mm, any with diameter more than 15 mm and associated with peripheral calcium dilatation. Now it has to be taken into consideration that it is or peripheral calcium dilatation and not and. So even in the presence of peripheral calcium dilatation, when the APD diameter is less, the patient still falls under intermediate risk. And in the high risk, any of the UTD classification parameters like bladder is abnormal, the kidney parenchyma is abnormal, and the diameter is more than 15 mm. Like in this case, on the sagittal film, we are seeing the renal cyst, and the bladder is thick walled. So this will fall in the high risk. Now, what is the use of categorizing the patients into low, intermediate, and high risk? It's basically in the follow-up. The patients with high risk are followed up more stringently every month, and investigations like VCOG, antibiotics, and functional scan are done in patients with high risk. However, the same are up to the discretion of the physician in the low risk and intermediate risk. Now, the role of chemoprophylaxis is not clearly defined. It is as done as in a study by Sile, it proved that higher grades of UTD like P3 or SFU4, boys with intact foreskin and those with VUR plus minus ureteric dilatation need antibiotic after birth. Now, when is it continued till? There is a controversy in that in low grade hydronephrosis, it is continued till the patient is having a VCOG and it is VUR negative. In case of no VUR, we stop the antibiotics. In case of VUR, we continue the antibiotics. However, in case of high grades of UTD, we continue the antibiotics till 2 years or resolution of hydronephrosis, whichever is earlier. The antibiotic preferred is amoxicillin or cephalaxin in the first 2 months and trimethoprim in infants. Now, role of VCOG. VCOG is basically for lower urinary tract evaluation. And as my topic is only UPGO-like obstruction, the role of VCOG in this case is limited because even if VUR is present, it is insignificant and it is present in up to 25% of cases. It will resolve on its own. Now, the role of renal scintigraphy. In children, MAC3 is preferred over DTPA because of the high extraction ratio of MAC3. Well-tempered renogram is advised in which all the variables are standardized. Exact role is not clearly defined. However, in patient with high-grade hydronephrosis like SFU 3 and 4, which is not explained by VCOG, that is the absence of VUR, we subject the patient to renal scintigraphy. Now, MRU, the role is unclear, but however, it is anatomical and it gives both anatomical and functional information. And need for general anesthesia is the only side effect which is associated with MRU, along with cost and availability in our settings. CT scan is to be condemned in the evaluation of antenatal hydronephrosis. When do we subject the patient to surgery? In case the patient has impaired split renal function, in case of decrease in split renal function more than 10% in the follow-up diuretic scan, poor drainage function after diuretic administration, increased AP diameter on ultrasound, and in case of symptomatic UPGO. Now, most of the surgeons do surgery at 2 years, but efficacy of surgery is best when it is done in less than 6 months. Options include open, laparoscopic, and robotic assisted, although there is no clear benefits of minimally invasive surgery. Now, Gyanendra sir published a journal in 2014 in which he gave a follow-up protocol. In case the diuretic renogram, the function is more than 40%, we place the patient on follow-up and a repeat renogram if the hydronephrosis increases on ultrasound. Whereas if the APD decreases by more than 10% in the prone position, the patient is again kept on follow-up, less strict follow-up, and the renogram is repeated at 6 years before stopping the follow-up.
Last minute.
Bilateral postnatal UPGO, it is assessed by serial sonography. The role of radionuclide scanning is limited. Intervention is done in the side deteriorating first, and surgery is done one side at a time because spontaneous significant improvement in contralateral side is documented. Our hospital protocol is the same as above, except for a few exceptions. We do a UTD, we do a scan every 4th weekly for all grades, and all cases of postnatal hydronephrosis are put on antibiotic prophylaxis. And we do pyeloplasty after 3 months. The transient hydronephrosis, a word on that, but it resolves by 4 years of age and is the physiological most common form of hydronephrosis. To summarize, antenatal hydronephrosis should not alarm the physicians or parents. Most of them resolve, need adequate follow-up, and patients need to be adequately counseled. The management of ANH constitutes of planning, multidisciplinary approach, counseling, and with respect to the specialty center, and all of them interplay in the management of antenatal hydronephrosis. Thank you.
So you can stop screening, stop sharing your screen. Thank you, Amit, for your presentation and also your mentor. This subject is almost close to everyone's heart. We start with the Chandra. Chandra from the CMC Vellore, our expert, will ask the first question.
Yeah, my first question is: are there any situations in the period before 6 weeks when you do the renogram that you may have to operate on a child, on an infant?
So in case of, like I mentioned, a severe bilateral hydronephrosis, in case of oligohydramnios, we do a scan within 48 hours. And if we see a function like parenchymal compromise is there and renal dysplasia is suspected, then we subject the patient to VCOG scan before that. And it is direct. Okay.
Sir, in solitary kidney also we can do the surgery as early as possible to save the kidney.
Yes, sir.
Ganesh sir is there? Dr. Ganesh? No, he's not there. Dr. Shyam Joshi, can you talk to me? You're unmute, sir. Yeah, you can ask your question.
Can you hear me?
Yes, sir.
Yes, sir.
Can you hear me now?
Yeah. Go ahead with your question, sir.
Dr. Amit?
Yes, sir.
Yeah. Amit, you have mentioned about renal scan in a very difficult way. You said in bilateral PUJ, you won't do the renal scan. And in your renal scan for unilateral hydronephrosis, you have not mentioned anything about cortical transit time. You don't believe in it, or you don't do it?
So renal scan.
Lastly, the last question is, you all mentioned is DTPA and MAG3. Is there any nuclear use?
Sir, I didn't get the second question, sir.
Sir, we lost your audio, sir. Yeah.
I can't hear him.
Sir, we lost your audio, sir. Technical staff, please.
I can't hear him.
Technical staff, yes, sir. We don't, but we are not getting your audio.
I think they have a internet issue.
Perfect. So you mute himself. You mute, please. You mute Dr. Shyam Joshi right now. So Amit, the question is that he wants to ask that what is the role of EC scan? You have compared the DTP and the MEC3, and another thing is that something about the cortical transit time. Do you consider in your practice any importance of CTT?
Sir, EC scan actually is not available in the hospital. We do only MAC3 for the initial kids. And MAC3 scan, the transit time within 48 hours if it is done, because of the dehydration status of the child, the transit time is increased.
Why you want to do any scan in 48 hours?
So 48 hours only
Oh, that is very rarity.
Sir, I think regarding EC scan is rarely available, but if available, it's better for children whose renal function is compromised. It is better to do an EC scan. Regarding the cortical transit time is the one which is used for analyzing the function, especially during the first 1 to 3 minutes. That is the one that we use to assess the differential function of each kidneys.
Okay. So, Dr. Paul, you can go ahead with your question.
One question which is related to the hydration dose. So if you have a patient with antenatal hydronephrosis UTD-P2 with AP diameter of renal pelvis being 15 millimeters, and then you go through your protocol of repeating the ultrasound, the second ultrasound, and then shows a dilation of AP diameter of 20 millimeters. What would you do next? The renal scan showed equal function initially with delayed drainage of the kidney, but there's now increasing in the degree of hydronephrosis at 3-month ultrasound. What's your next step?
So in case the hydronephrosis is increasing on follow-up ultrasounds, this is an indication for repeat renogram. And repeat renogram, if the function is deteriorating below 40%, then we have to subject the patient to surgery like pyeloplasty.
What about the hydration level of the child? Would you look at that as a possibility of the dilation?
Sir, hydration status is basically taken into account in the first 48 hours, and this repeats can be done at 1 month.
No, sir. Regarding hydration, the hydration status of the kid is very important when you are doing a renogram, because we have to properly hydrate the kidney, child 30 minutes before the renogram. Otherwise, you can get a false positive result.
So that well-tempered protocol is there, in which we hydrate before and during the scan. Also, maintenance dose is going on, and all the protocols has been standardized. And after that, only DTPA results are being interpreted, sir.
Okay, Mallikarjun, go ahead with your question.
Okay, Amit. Let me take you a little away from the PUJ. So tell me what other indices would be better in terms of predicting that this particular child would need an intervention or not. Like I may probably give you a hint saying that probably you talk about the urethral diameter ratio.
Sir, few things are there which is mentioned. First is the, as you mentioned, urethral diameter ratio is there, in which the length of the ureter into the pelvis is compared with the pelvis diameter. And if it is more than 0.3, then it is suggestive of intervention in the fetal kidney. And it was given by Kenagi or something. I am not sure about that. And second thing is, second thing is the antenatal diameter more than 12 mm. More than 12 mm usually does not require a fetal intervention in the postnatal period.
No, there's a situation which I am looking at literally, that you have a hydronephrosis, you have a long ureter, a large ureter, and then what would your take that you just don't see just the ureter or the DTPA or a MAG3, say that that particular kidney is obstructed, because if there is obstruction lower down, it is not easy for you to decipher that. So what are the other parameters you would look at to say that probably this kidney is obstructed and it needs some intervention, or this kidney can be followed up safely?
Sir, I mentioned pulse Doppler, we can see the resistive index of the intrarenal arteries. If it is more than 0.7, then we compare the resistive index between the two arteries, between the two kidneys. If it is more than 0.1, then the ureteric jets we can see in color Doppler ultrasound. And Gyanendra sir has published a paper in which we make the patient prone. And if the improvement is more than 10%, then that means it is not obstructed.
Sir, some other factors are also widely studied, like hydronephrosis index and all. That is the ratio between the PCS area to the parenchymal thickness, the thickness of the parenchyma. Several things have been studied, but most of them are not included in the protocols for follow-up.
Oh, going to Dr. Ansari. Dr. Ansari.
Last minute to go, sir.
You have still 1 minute. Yeah, go ahead.
Okay. So no problem. Dr. Amit, just reply me, listen carefully. What is the indication of cesarean section in unilateral antenatal hydronephrosis? You have to tell me one urological cause where you will say, yes, go ahead.
Sir, your audio, last couple of words, sir.
Unilateral UPG obstruction.
Hello.
Yeah. Kruti, stop here. Dr. Ansari, would you like to? We would request you to repeat your question, sir.
Sir, repeat your question. Amit, yes, I'm repeating. Just tell me one urological indication of cesarean section in unilateral antenatal hydronephrosis.
Sir, unilateral antenatal hydronephrosis. You can
just think and then reply.
Sir, if there is a severe oligohydramnios and the child has attained a pulmonary maturity.
Unilateral UPG obstruction.
Unilateral.
Yes. Okay. So back to Dr. Anil.
Yeah, you can take a last question, Asim. Asim, you can take a last question.
Okay. Excellent. So Amit, my question to you would be that with antenatal hydronephrosis, you spoke about using antibiotic prophylaxis. If you think about kids with antenatal hydro, what do you think is a risk factor for a UTI? what are risk factors for UTI? Give me your justification for putting a child on, which child would you put on antibiotic prophylaxis with antenatally detected hydronephrosis? That's my question.
Sir, antenatally detected hydronephrosis in case of bilateral severe grade 3 or grade 4 hydronephrosis. In case a patient has a solitary kidney with a hydronephrosis, and in such cases, we'll put the antibiotic prophylaxis right from the birth. So we don't, and the scan is also done within 48 hours in this cases. So I believe severe bilateral hydronephrosis is an indication for putting the patient on antibiotic prophylaxis. Sir.
Do you know what the single biggest risk factor is for a UTI in children with antenatal hydronephrosis?
If it is associated with V or
yeah, I mean, this was not really the question, but I didn't ask it properly. But what I wanted to say is that doing a VCUG on univariate analysis is a risk factor for getting a UTI. So I think you want to be very careful in ordering VCUGs.
Yes, sir, indeed.
So I think that comes to the end of your presentation and question answer segment. Thank you, Amit and his teacher from the Trivandrum. And before we move on the next presentation, we have some time. So here I would like to ask Professor Ansari, sir, how you could cover the pediatric urology department in the most prestigious, one of the prestigious institute of India, that is SGPGI. What it took to. Sir, unmute yourself. Unmute, Ansari, sir.
Yes, sir. So I'm audible now?
Yes.
Yes, sir. See, if you see in most of the medical college and the all institutions, there is already urology department as well as the pediatric surgery department. And traditionally, the pediatric surgery department has been the guardian of pediatric urology, and partly it was taken care by the adult urology. And there is a third set to which SGPGI belonged initially. There was adult urology, full-fledged with some concept of a subspecialty. But my initial days, for initial 3-4 days, there was no pediatric surgery. So that gave me a platform and basically a fertile field to grow pediatric urology. So if you are having right from the beginning a pediatric surgery, full-fledged pediatric surgery, then the things become difficult. And that is why there are several models like All India Institute of Medical Sciences, CMC, Vellore. And I think Dr. Chandra will vouch and support me, where all then things become little difficult and slow. For my initial 3-4 days, things moved very fast because as such there was no pediatric surgery department. After 4 years of my starting, by the time the pediatric surgery came, I had started a pediatrics urology fellowship. So that made me a academically, or you can call me a legal guardian of pediatric urology. Otherwise, this would have slipped into the pediatric surgery indirectly.
Okay. And
So,
one more question.
This is how the things moved.
See, one more question is that last year when you invited us, Venki was there, I think Chandra was there, and there were 3 faculties from the job, and we were all taken to the round, and we were all surprised, not only surprised but shocked with the volume of the patients. So, can you tell us what exactly the monthly volume of pediatric urology work in your department? Because we could see 8 patients of DSD, 8 patients of 10 patients of high-grade reflux with a scar, number of PUJ, number of whatnot, varieties of hypospadias. Always, all were fighting for these hypospadias for me. Yeah.
Yes,
some
almost
audio
the
corrections.
Yes, Department of Urology is having at Lucknow almost 100 beds, and out of this 1/4 are usually basically kept separate for pediatric urology, and we are running almost 4 operation theaters. So it is not a matter of how many beds or patients you will have unless you have full OTs. So the advantage at my center is that we are having 4 OTs and 5th is the robotic OT. So that makes me to hold so many patients.
Okay.
So
and do
this
you
was
have
the reason why you get.
And do you have a fellowship there? pediatric urology?
Yes, fellowship almost started 8-9 years ago. Yes, initially it was started with one. Now for the last 2 years we are having 2 posts. One is starting in the month of January and the another is starting mid-June or July of every year.
Okay, thank you, sir. Thank you for this information, wonderful information. So that takes me to the fourth presentation, and you can start sharing your screen, Bhomik.
Right, sir.
So Bhomik is from the Chennai, and his teacher is his mentor is Dr. Ramesh Babu. It's a team Chennai, and their topic is evaluation and treatment of urinary incontinence in 5-year-old female child. Okay, you can go ahead with your presentation. Your presentation start now.
Right. Good evening, judges and faculty members. Myself, Dr. Bhomik, with my teacher, Dr. Ramesh Babu. Greetings from Chennai. Today, my topic of presentation is on evaluation and treatment of urinary incontinence in a 5-year-old female child. What is incontinence? In 2016, the International Children's Continence Society defined incontinence as a involuntary leakage of urine and a nighttime leak as a enuresis. They have divided incontinence into continuous incontinence and intermittent incontinence. And intermittent incontinence can be daytime enuresis, that is nighttime. Enuresis can be monosymptomatic or polysymptomatic, that means associated with other symptoms. It can be primary or secondary, that means more than 6 months of symptom-free interval. So we need to know the etiology of urinary incontinence in a 5-year-old girl child. It can be functional, neuropathic, or a structural cause. The commonest cause of functional diurnal incontinence is a voiding dysfunction or urge syndrome. The commonest functional cause of nocturnal incontinence is enuresis, also known as bedwetting or a monosymptomatic nocturnal enuresis. Neuropathic causes comes third. It includes spina bifida, myelomeniingocele, sacral enuresis, tethered cord. And one should exclude the structural causes, which always represent the first priority, and it includes ectopic ureter and epispadias. History taking is very important tool. We need to ask 3 important questions. One, whether it is continuous or intermittent. Is it new or it has been there since birth? Is it a problem during night, day, or both day and night? Any preventive body posturing like leg crossing is there, squatting, also known as Vincent's curtsy? Are there any features of the bladder instability in the form of urgency, frequency, or urge incontinence? Here, voiding diary, or also known as frequency volume chart, plays an important role. It gives many clues. Like International Children's Continence Society defined increased frequency when there was more than equal to 8 voids per day, and decreased when there was less than equal to 3 voids per day, as seen in the lazy bladder or deferred voiding. And maximum voided volume as the percentage of estimated bladder capacity gives a clue. Like it is considered low if it's less than 65%, and it is high in more if it's more than 150% of the estimated bladder capacity, which is suggestive of deferred voiding or lazy bladder. One should look for the holding maneuvers like Vincent's curtsy, penile squeezing, leg crossing, along with the Bristol stool chart to evaluate patient with the bladder bowel dysfunction. History gives many clues. Like if the patient is having pure nighttime incontinence, it can be because of monosymptomatic nocturnal enuresis, and if it is continuous day and night wetting, then organic causes are more likely. And if it is intermittent daytime wetting, then functional causes are more likely. And if it's associated with the bowel problems like constipation, then it can be there in the functional or neurological causes. If a 5-year-old girl child wet soon after voiding, then it can be because of vaginal reflux, also known as vaginal voiding, and simple body posturing recorrection can be a treatment of choice. Clinical examination, abdomen may reveal palpable bladder, expressible bladder, which is indicative of neuropathy. Fecal loading can be indicative of functional or neuropathic causes. spine should be looked for the hairy patch, swelling, old surgical scar, and one should do neurological examination to elicit gait, lower limb reflexes, sacral reflexes, lower limb vesting. And local examination in a 5-year-old girl child may reveal labial synecdoche, and with the simple separation of the labia under anesthesia is what is needed. Sometimes bifid clitoris gives a clue to epispadias. Flat sacrum can be suggestive of sacral agenesis. Tuft of hair can be suggestive of spina bifida occulta. When to suspect ectopic ureter? When the patient has always been wet and the examination reveals soge genitalia like in a washerman's skin, and there is a normal voiding cycle like fills and empties with a good bladder sensation, and there are no features of instability or neuropathy, then one could think of ectopic ureter. On evaluation, the X-ray abdomen, X-ray spine, urine culture, renal function test are the primary investigations, along with the ultrasound, which may reveal duplication anomalies, upper tract dilatation, bladder wall thickening, PVR. And Euroflow EMG can be a very useful tool, and the VCUG, MRI, urodynamic studies are very useful. X-ray abdomen may be suggestive of fecal loading. X-ray spine may represent spine abnormality. VCUG may show spinning top urethra, which is indicative of dysfunctional voiding, and the Euroflow may show staccato pattern, which is indicative of voiding dysfunction. From our institute in 2015, we published our experience of role of uroflowmetry with EMG in evaluation of children with lower urinary tract dysfunction. Here it is a normal uroflow curve with the silent pelvic floor muscles. And we have identified 3 patterns. Like if there is a prolonged staccato trace and uroflow with active pelvic floor with normal voided volume, it is suggestive of dysfunctional voiding, and a biofeedback is the treatment. When there is a shortened tower-shaped flow curve and uroflow with white pelvic floor along with the reduced volume, it is suggestive of idiopathic detrusor overactivity, and the anticholinergics and the beta agonist can be a treatment of choice. And the prolonged flat trace along with the white pelvic floor with large voided volume is indicative of detrusor underutilization, and the behavioral therapy or the timed voiding is a treatment. Here is the a picture of biofeedback where child is being taught about the regarding contractions and relaxation during the voiding. Ectopic ureter can be identified as a drooping lily sign on IVU or CT urogram. It can be present as non-functioning upper pole on DMSA, and MRI can actually reveal ectopic ureter which is going beyond the bladder neck. In 2016, from our institute, we come up with the results of duplication renal anomalies in children and management, where when there was no functioning of the upper pole, we did lap heminephrectomy. When there was a functioning upper pole, we did lap ureterostomy. Neurogenic bladder can be identified on ultrasound with the presence of a thickened bladder wall or increased PVR, and the voiding cystourethrogram may show Christmas tree appearance, and the urodynamic clinches the diagnosis by presenting unstable bladder contractions and poor bladder compliance. So treatment of neurogenic bladder should be a stepwise pattern, like we'll start with anticholinergics plus clean intermittent catheterization. If it fails, we'll give Botox injections. If it fails, then augmentation and metrophenol can be tried. In 2006, we came up with our experience of tolterodine in neurogenic non-neurogenic voiding dysfunction, which was published in Indian Pediatrics. And in 2012, we published a novel technique of bladder augmentation, a distal ureterocystoplasty with proximal ureteric reimplantation in the treatment of neurogenic bladder. Last but not least, monosymptomatic nocturnal enuresis is a common entity, but the problem is it is a diagnosis of exclusion. And the behavioral therapy is the treatment where the child is asked to void just before the bed. We have to ensure easy access to the bathroom and adequate lighting, and the star charts along with the reward dry nights are particularly suited in the younger patients, and desmopressin in the case of nocturnal polyuria, and the bedwetting alarms in case of the arousal problem. To finalize my talk, The management of the 5-year-old girl with the incontinence. Here, the history taking and the bladder diary are the crucial ones. Along with the prompt clinical examination, will provide us a broad idea about the problem. It can be functional problem, it can be neuropathic problem, it can be structural problem. We will do basic investigations like X-ray abdomen, spine, renal function test, urine culture, and ultrasound. If ultrasound is showing any abnormality like bladder wall thickening, trabeculation, increased bladder, increased PVR, then we'll go with the VCUG. Otherwise, functional problems can be identified on Euroflow EMG, and neuropathic causes can be identified on MRI, urodynamic study, and the structural causes can be identified on CT, MRU, and the management of the girl child with the urinary incontinence based on the etiology. Thank you so much.
So, thank you, Bhomik. Answer your screen. Yeah. So with that, thanks to you and Dr. Ramesh Babu, your mentor. And there, I will request Dr. Asim Sukla to initiate the first question.
Thanks. Very nice, Dr. Bhomik. When you counsel a 6-year-old girl with daytime and nighttime enuresis, and you spend time with the family, what are, and there's no neuropathic causes, regular bedwetting, I'm sorry, regular day and nighttime wetting. You talked about getting a bladder diary. You have a normal spine exam. What recommendations do you give them for their first 3-month period before you see them again? Do you go to urodynamics? Do you get a renal ultrasound? Or what do you tell them on your first visit as they leave your office? What recommendations do you give them?
Right, sir. When patient comes to our OPD, I will take brief history about the problem. Along with, I'll suggest bladder diary. It should be ideally continued for the 14 days. And I will go with the physical examination to look for any structural causes, which can be identified like soggy genitalia or epispadias. And I will try to rule out structural causes first. And I'll suggest bladder diary, and I'll call the patient.
Do you give them any recommendations on water drinking and constipation management? You spoke about that. I want to hear what you tell them for their, for routine daily life.
Right, sir. I'll give if there is any complaint of constipation, I'll recommend lactulose along with the water, because if only lactulose will precipitate the problem, so I'll recommend lactulose along with the plenty of water.
So we move into the Ganesh. Dr. Ganesh has joined. He was finding some difficulty. Still not there. Then Malik, this is topic given by you, so you can ask one question, quick question. Yeah, Malik. Unmute yourself.
Yeah. Okay, Bhomik. To follow up what Dr. Asim has asked, actually, that do you recommend lactulose as a first choice of laxative or something else as a first choice? That's number one. And number two is, if you don't have significant any other signs leading to occult spinal dystrophism, but then how would you suspect that this particular child would probably, what is an indication for an MRI when you still don't have signs of occult spinal dystrophy?
Right, sir. First of all, we can give isabgol along with the water instead of lactulose. And in case of occult spina bifida, I will first examine the patient, and I will examine the gait, lower limb reflexes, sacral reflexes, and the vesting of lower limb muscles to identify cause. And I'll give bladder diary to the patient, and if I suspect a neurogenic cause, then I'll recommend MRI.
Okay. So we move. Is it okay, Malik? We move to the poll. Paul, you can ask the question.
One question for you. So you have this 5-year-old. You've treated the way you've described. And the incontinence continues. You've done all the studies. Neurological studies are normal. You've done biofeedback. What do you think is the role of things like neuromodulation in the management of incontinence?
Right, sir. Neuromodulation is a technique to improve the function of the system or the organ by applying electricity. It can be done in two ways. Like first is a sacral modulation, which is an invasive procedure, and the second one is a transcutaneous electric nerve stimulation, which can be applied on the posterior tibial nerve supplying area. So yes, it can help, sir.
Okay. Dr. Ansari, go ahead.
Yes, I will just start the first question, which is still not very satisfactory. You just tell me, Dr. Bhaumik, how many children or you or your mentor has seen have eaten isabgol happily to manage constipation? We are talking of 5-year-old child.
Dr. Ansari, audio. Keep little away.
Are you getting, Bhaumik?
Now, but keep it.
Yes,
okay.
I'm just asking because Bhaumik replied that he will give isabgol to a 5-year-old kid. How many 5-year-old kids they would like to have isabgol to get rid of constipation? I think Bhaumik is not connected.
No, he's connected. He's thinking. You want to think or you want to take another question, Bhaumik?
Yes.
Next question, please, sir. Sorry.
So you can ask
Okay, just I can give you another question. See, okay, so you showed a series of duplex. I just want to know how much you have learned. How can you predict during counseling, the child will not have continued incontinence?
Sorry, sir.
Sir, again, Dr. Ansari, you need to repeat your question. Don't count this time,
Yes.
Kruti.
Yes, sir. In cases of duplex, kidney with ectopic ureter, you want to ensure parents that after correction of this ectopic ureter, the child will not be having incontinence. Can you tell me one test which can guide you to counsel parents? Ectopic ureter in duplex kidney, child is incontinent. You are going to counsel parents that after correction of this ectopic ureter, whether you reimplant it or do nephrectomy, depending on the function, where you can tell that the child will not have continued incontinence after correction of this.
Can I help you, Bhaumik?
Yes, sir, please, sir.
Yeah. See, in your in the symptoms, if there is an element of underlying voiding dysfunction or already bowel bladder dysfunction, removing the ectopic ureter alone will not be helpful. So I have to be absolutely sure that the ectopic ureter is the only reason for this problem. So I have to evaluate and then warn them that, if there is an associated element, another element of bladder component also, then your ectopic ureter treatment alone, like an upper pole nephrectomy or whatever, may not be enough.
I am asking the test. The parents will ask, sir, what test my child has to undergo to predict that?
Last 1 minute to go.
Okay, Venkatesh, you can ask question. Are you there? Yeah, unmute yourself, sir.
in all these patients, most often before you jump to MRI, your clinical examination and history taking is important with the counseling. So you look at what has been asked earlier. If everything is normal and you find that this child continues to have incontinence of whatever degree, what are your other options?
Other options like I'll give a behavioral therapy to the patient to options. I'll start on behavioral therapy, sir, and I'll rule out any mental. I'll try to rule out any instances of mental trauma to the patient.
Okay. Yeah. So I could see now Ganesh. Ganesh, would you like to ask? Ganesh, sir, you would like to ask question? I think he's still not audible. So can you take Sim last question?
Did you say me? I'm sorry.
Yeah,
I didn't
yeah, please.
Okay, okay. Well, I think what I would ask is, in which patient, Bhomik, would you consider a urodynamic study? You have a child who you have a normal MRI spine. You put them on lactulose. You've had them on regular diet. Would you consider urodynamics, and what treatment would you offer? Let me put it this way. What treatment would you offer a child who has failed constipation, water drinking, and time voiding management? What would be the next step that you offer that child for treatment?
Sir, I'll offer Botox injection if above mentioned modalities fail to respond.
Without urodynamics or after urodynamics?
After urodynamics.
What on urodynamics would make you consider offering a Botox injection? What findings on urodynamics?
Unstable bladder contractions and poor bladder compliance. Then I'll consider Botox.
Okay. So let me ask the last question. Bhomik, what do you think? What is more detrimental? It is occasionally voiding at high pressure or storing continuously at the safe pressure level?
High pressure voiding is more dangerous, sir.
There is a patient occasionally voiding with the high pressure, and there is a patient who is storing the urine continuously at high pressure than what it should be. Which is more detrimental to you?
Sir, again, high pressure voiding is...
Okay, perfect. Okay, so that is probably, I think, Kruti, his time is up.
Yes, sir.
Okay, fine. Thank you, Bhomik. And so before the judges put their mark, I would like to ask, actually, this question I wanted to ask Dr. Ganesh, but Ganesh is probably... Are you in position to talk to us, Dr. Ganesh? Ganesh, sir? No. So, Chandra, could you tell us that what do you think in India? Do you think that we are moving towards the best practice, or you can say fairer practice in the field of pediatric urology over time? Means our understanding probably improved, and we are now not doing much unnecessary investigations or much unnecessarily surgeries. Do you think that we are marching on that side, or we have reached to that level, and what further we have to contribute or do for the best practices in the pediatric urology? Because pediatric urology is an area where you have witnessed the excess of almost everything, and now over time we realize that no, we have done really excess. So tell us your experience in working in the very major institute, or you can say one of the finest teaching institute.
Thanks, Anil, for that. I believe that putting all our expertise together, we are marching towards that. because we have the best of technology, best of neonatal care, and best of diagnostics, and best of multidisciplinary approach. And I believe that in the near future, we'll be there in a position to offer the best. For example, recently we had a child who had a bladder stone, ureteric stone, and a renal stone. And we had to do a laser fulguration of the bladder, URS and a mini perk together. So this is in stones, but in reconstruction as well as in terms of the functional bladder management, we are able to offer things together. And I do believe that with collective input, we'll be able to significantly offer something far better in the near future. I think the future is promising.
Another thing is, do you think that in spite of a lot of talks, we still see the overuse of, you can say, CT scan or maybe sometime IVP or excess use of VCUG? Do you still see this kind of incidences or things in your practice?
You're right, Anil. Unfortunately, all those tests are done before the children are sent to us. So I feel we do have a lot of role to play in educating our pediatric colleagues. So that is why when we send back the children who are treated, we give the algorithm or how we manage as a letter to the children. We have children who travel usually 1,500 kilometers when they come. So we don't personally know the pediatricians, but nevertheless, saying them as a summary which has a discussion and the thought process and telling the patients, parents to inform the pediatricians enables us to educate them. But I think we need to conduct something similar. I think you can take that as of now that is a successful assignment for pediatricians. What are the basic issues which are relevant to pediatric urology? We can conduct similar programs which are educative as well as competitive.
So we are really thinking seriously with the help of our dynamic secretary Rajiv. We will be very soon have some this kind of a seminar with a large number of pediatricians participating in that. Thank you. So judges have put their mark, and we move to the last presentation, that is from the Naresh Kumar. He is representing the West Zone. He's from the Mumbai Nayar Hospital, and he's with the teacher Tarun, Dr. Tarun. So Naresh, you can share your screen.
Am I visible?
Yeah, visible. Make it full screen.
Not able to read.
Can you say a couple of, how are you?
I'm good, sir.
Okay, fine. So you can start your presentation. Your time starts now.
Good evening, everyone. I'm Dr. Naresh from Nayar Hospital, Mumbai. My topic for today is causes of failure in proximal hypospadia surgery and principles of redo surgery, done under the guidance of Dr. Tarun Jain. So I'll cover the topic under the following subheadings. That is, what defines proximal hypospadias? What defines failure of hypospadias repair? What are the causes of proximal hypospadias? Causes of failure of proximal hypospadias repair? And what are the principles of redo surgery? So Hadidi in 2004 classified all hypospadias proximal to the mid shaft as proximal hypospadias. It was later in 2012 that Marek used the level of division of corpus spongiosum in respect to the level of pubis to classify hypospadias. So if the corpus spongiosum division occurs proximal to the level of pubic symphysis, it's called as proximal hypospadias. If it's distal, it's called as distal or penile hypospadias. So what defines the failure of hypospadias? Primary surgery that does not achieve the cosmetic or functional goals of a straight penis is defined as failure, which can be both subjective or objective. Subjective deals with the patient considerations, whereas objective include the complications that require surgery. To be kept in mind is that the complications increase as the duration of follow-up increases. Overall, the rate of complications has been found to be around 23 to 68% in proximal hypospadias repairs, which most common being fistula, followed by meatal stenosis, stricture, and others depend on the type of procedure used. Skin complications like skin surplus, tethering, penile torsion are also seen. Complications were graded by Van der Werf into grade 1 or minor complications, grade 2 or cosmetic complications in which reoperation can be optional, or grade 3 or major complications like fistula, diverticulum, dehiscence, recurrent curvature, or stricture for which reoperation is required. Causes of failure in proximal hypospadias repair can be divided into general or specific. Coming to the general, it has been seen with increasing age, the complications increase. Preoperative hormone stimulation has been found to be controversial with most people using it to increase the glans or penis size preoperatively. Again, suture is a controversial thing, but recent studies have found similar rates of complications with either PDS, Vicryl, or catgut. The complications vary according to the technique used, and depending on whether it's a one stage or a two stage, whether it's a Snodgrass, only eyelid flap, or a tube repair. Postoperative drainage has been seen to reduce complications in proximal hypospadias repair. Specific causes deal with the anatomical causes as well as the surgeon experience. Anatomical mainly dealing with the smaller glands, narrow urethral plate width, longer neourethra that has to be formed, increased tissue dysplasia, and the body. So it has been found that gland size less than 14 mm and a urethral plate by glans width ratio less than 0.36 is associated with increased complications. Similarly, a narrow urethral plate less than 8 mm is associated with increased complications. As the meatus becomes more proximal, a longer neourethra has to be formed. And in accordance with Poiseuille's law, the longer the tube, the higher the resistance and higher complications. Even in cases of onlay flaps where the resistance is low, they are prone for complications like diverticular or stricture. With proximal hypospadias, the tissue is immature and dysplastic and has impaired healing. Even there is disproportionate growth of the ventral aspect of the penis, which can present as complications later on. In cases of CODI, we require extensive mobilization or urethral plate transection that can compromise vascularity and hence increase complications. Surgeon experience remains a critical factor, and it has been found that an initial learning curve of 2 years and 50 cases and a case output of at least 50 to 75 years per year is desirable. So what are the principles of redo surgery? Basically, we are dealing with a short, scarred penis with lack of vascular tissues and deficient local tissue as well as skin. And on top of it, we try to attempt smaller operations to overcome the complications which can be counterproductive. In the pre-op, there has to be an adequate assessment with assessing the history as to what type of repair was done, local examination to look for the scars, the penile skin, the prepuce, and the glans size, the urethral plate width. Also look into the complications like fistula, the recurrent curvature, any stenosis or stricture. It is prudent to wait for 6 to 8 months after the primary surgery to wait for the tissues to become supple. Intraoperatively, the basic principles remain the same with delicate tissue handling, excision of all unhealthy tissues, redistribution of well-vascularized tissue, using subcutaneous tissue sutures, avoiding tension, and providing a superimposition layer over the suture lines. In cases of a major redo surgery, we have to ascertain and correct the penile body initially, followed by replacement of the defective urethra with a well-vascularized tissue, and finally, reconstruction of the ventral surface of penis. In cases of small fistula, it is necessary to excise the cornu and provide a second layer coverage over the suture line. In cases of meatal stenosis or stricture, if the conservative management fails initially, we'll have to go for a meatoplasty or a urethroplasty later on. Glans dehiscence, in most cases, the redo surgery would not be needed, but in diverticulum needs excision after ruling out distal obstruction. So in cases of a major dehiscence or a recurrent curvature, a redo surgery with a declaving and a GTS test is done, and assessment of CODI is done. If after dorsal plication, the urethral plate is adequate, a Thiersch two-play repair can be attempted. In an inadequate urethral plate, either a Snodgrass, Snodgraft, or an Olney island flap is preferred. If we have to transect the urethral plate, either a one-stage ducket or a SOPA, or a two-stage Byers or BRCA is preferred. In our institution, we give testosterone if it is indicated. Pre-op antibiotic is given at induction. Anesthesia is general anesthesia with local infiltration. It is done by our seniors or under their guidance using magnification. We prefer PDS over Vicryl, and our preferred procedure is only island flap. But if the urethral plate is to be transected, we use a two-stage Byers flap. Post-op drainage with a Nelcath or a Silastic hypospadiatic stent. Dressing is done with gauze and micropore fixed to the abdomen. Post-operatively, patient is started on anticholinergics and antibiotics, and dressing is opened on day 5 with catheter removal at day 10. For redo cases, we err on the side of major reconstruction if needed. These are the intra-op photos of proximal penile hypospadias for which after declaving, we did the Jitte's test and raised an inner preputial flap to use it as an onlay over the urethral plate and finally covering with a Byers flap. A post-op case of fistula formation where 2 fistulas were present were made into a single fistula here, closed primarily with PDS, given a local Dartos flap coverage, and finally the skin was closed. In a study studying 48 patients to predict the factors associated with success in ASOPA's procedure, we found that there was increased complication rates with proximal hypospadias. The complications increased when the tube repairs were used as compared the onlay flap repairs. Age was a factor. With progressing age, the number of complications increased. Also, we found that the glans configuration is important with increased complications in a conical glans. As far as the surgeon experience is concerned, we found that the initial 2 years, there were more complications as compared to the later 2 years of the study. In conclusion, proximal hypospadias often requires more extensive reconstruction, along with maintaining adequate vascular supply and a multi-layer closure, either in a single or a 2-stage, to achieve satisfactory outcome. Redo surgery done by an experienced surgeon following the principles meticulously can avoid a hypospadias cripple. Thank you.
So thank you, Naresh Kumar, Amilal Bhattji is waiting since long, and sir, you have to now start the questions. Ball rolling. Yeah.
Thank you, Anil. At last,
Sir.
while ask few basic, you are dealing with the proximal hypospadias. What other evaluations you will do?
So, if the patient presents with a non-palpable gonad, then we'll have to rule out DST first before the procedure. That is the most important thing.
So what are the other signs which are available on local examination when you suspect DST?
We can have a bifid scrotum with a pinoscrotal transposition, an impalpable gonad, or either unilaterally or bilaterally.
Something more which is visible on that perineum if you see.
The anogenital distance can be increased.
Okay. What are the indications of radiological evaluation?
If in the prenatal evaluation, if there is any presence of, we find any presence of Mullerian duct structures, that can be looked in for the radiological evaluation. Or there are lesser cases of associated vesico-ureteric reflux or hydronephrosis that can be looked at in the radiological evaluation.
What else could be in the proximal hypospadias which gives problem post-operatively? Anyway, leave it. I'll ask one. What is the single most important factor in proximal hypospadias? You have mentioned age and site of the meatus. These are two. Then what is the third one which is more important for the results?
I think it's the surgeon's experience and
that you have told.
Anatomically, the
patient profile.
The urethral plate, how supple is it? That would be with or without the presence of chordae. So chordae and urethral plate.
Chordae and urethral plate. Spongiosum. Development
yes.
of the
Yes. Ventrally, the development of how thick the spongiosum is.
When do you call the hypospadias cripple?
When
Anil, you can take any time.
Yes, sir. Yes, this is your last question here. Go ahead, sir.
When there are multiple failed surgeries being done, already done, so it's called as the hypospadias.
What is the definition? It's not multiple. Multiple may be 5, multiple may be 3, multiple may be any.
More than 2.
No. So the answer to that will be a deficient tissue with or without chordae with a minimal length of penis available for reconstruction. That would be a definition of a crippled penis.
Last question. What are the 4 principles for doing or repairing the redo hypospadias? 4 things which they call.
Naresh.
Sir, we have to initially see whether there is a recurrent curvature. We'll have to correct it at the first moment. And if the urethra is irregular, if there is any stricture that can lead leading to a diverticula or a fistula, we have to rule out that. And we don't have to take a minor procedure for complications. Even a fistula, when we explore, it might need a redo urethroplasty. As well as we have to give an adequate coverage post-operatively.
So I'll try and summarize what Naresh is saying. So the 4 basic principles: good adequate coverage, vascularity, remove the chordae during the surgery, and try achieving an anatomically normal penis where the void is from as near as the tip of the penis as possible.
Okay.
Anil, you can take.
So Dr. Ganesh, are you there? This is the last chance for you to ask question. Because he was struggling for his connecting. So that's why I'm repeatedly asking.
I think
he's still not there. Okay. Okay. So Dr. Paul, you please ask the question.
I'd like you to clarify a little bit about the ventral curvature. I mean, you can argue if it's chordae or ventral curvature, but how do you measure curvature and measure adequately? When you talked about dorsal plication, when would you do dorsal plication versus ventral elongation with the transection of urethral plate? Are there indication when you use one versus the other?
Yes. So Naresh, I'll answer this. So first of all, how to define chordae? It will be done operatively with the help of Gitti's test. Secondly, whether to do a dorsal plication.
How would you measure the angle, the degree of chordae? Is there a way to measure this?
Naresh?
Goniometer. Yes. With a goniometer, sir. Or by a visual inspection, but that is not very perfect.
Correct. So whether to do a dorsal plication or a ventral elongation, that will depend on what is the length of the penis that we are dealing with. If the length of the penis is adequate, we can actually do a dorsal plication, but that will that actually does not treat the chordae. It just treats the chordae, but at the same time reduces the size of the penis. However, if you are dealing with a crippled penis, or the size of the penis itself to begin with is very small, we might have to do the elongation procedures from the ventral side.
What if you have a 45-degree curvature?
I think we might require both the ventral elongation plus or minus plication. So we might need to do both.
There's some proponents who basically classify it 30 degrees below or 30 degrees above for plication versus urethral transection and elongation.
So is it okay? So we move to the Asim. You can ask a question.
I just want to be sure everyone had a good chance to ask questions, Anil Bhai. I've asked a lot of questions. Many people have a passion in hypospadias, so let me defer to others.
Okay. Dr. Ansari, yeah, go ahead.
I just wondering, because the part B of your talk was the principle. I was more interested to know the principles of repair, but somehow they were missing. So you reply me, when you go for management of these failure of cases, what is the basic principle of Johansson's urethroplasty and Thier's two play? You tell me the difference between the principle, because the part B of your talk was principle. Johansson's urethroplasty and the Thier's two play urethroplasty.
In Thier's two, we do not divide the urethral plate, we just tubularize in Thier's two play, whereas in Johansson's, we remove the immature tissue and put in a buccal graft in the stage 1 and then later tubularize in the stage 2.
I think we need to read it again.
Okay. Dr. Anand Kumar, probably you wanted to ask one question. Sir, President Sir, you can go ahead with the one question. Unmute yourself, sir.
I
Sir,
think
unmute.
most of the questions are asked in hypospadias, and I think some of the he could answer, some of the he could not answer. So
Okay, okay, no, but he's having a 1 minute. Let me ask you a question because at least someone need to ask the question. How frequently you get this hypospadias cripple, and what exactly you do when you get this patient into your institute in your 2 or 3 years experience, and what exactly you figure out the reason for the hypospadias cripple?
Sir, it's not a very common because procedure, but whenever we get it, the thing we are worried about is the lack of tissues. So either we for the making the coverage of the urethra, we can either go for a local tissues if they are available, or then we can go for a sessile culp where it's buried into the scrotum.
So it will be the stage procedures. How you explain means how many stages generally, and how you communicate with the relatives.
It is always told to the relatives that it might be a 2-stage procedure or even more than that. And if we are not able to even close the urethral plate, then we'll go for a 2-stage procedure for either grafting or either using a buccal graft or a prevutial graft. Or if we are lacking for the ventral skin cover, then we can go for a sessile culp modification.
Okay, so that I think Kruti, his time is up.
Yes, sir.
Yes. Okay, fine. Thank you, Naresh, and thank you, Taran, sir. And with that, we come to the end of this all 5 presentations. And thank you very much to all presenters and their mentors for these beautiful presentations. And we have to give judges at least a couple of minutes, and during that, we'll continue our sharing thoughts as well as observations. So let me start with our international guest, Dr. Paul. Can you share your observation on this particular session and presentations and the level of competitions and all those things, sir? Please.
I think one of the things that I took from this, the presentations, all of them were superb. Every one of the presenters presented adequately. This is going to be a very tough decision to make here because the presentations are so varied and they were all very well presented. The participants were engaged, they were knowledgeable, and that is my observation. I think the level of the talks were superb.
Okay, Asim, would you like to share your thoughts on this particular these student teachers, you can say, webinar public competition here?
Yeah, as I started right in the beginning with, I think, Sumit's talk, and it continued the theme throughout, really impressive, comprehensive hold on topics. These were broad topics with a lot of fields and with a lot of subdisciplines. And I was very impressed as to how these trainees really sort of integrated all of the concepts into an excellent presentation. I thought they were visually very good. I thought the content was strong, and it underlies what I said in the beginning, that the level of pediatric urology in India has undergone an absolute transformation. It's really just top of the line, better or as good as I would ever expect from a fellow or resident here in Philadelphia. So yeah, great job.
Can you share a couple of thoughts that still how can we improve the best practices in the field of pediatric urology, because this is the most probably affected field for a couple of years of access investigations, access procedures, and over time we learn. Maybe it is a learning process, but still there is a lot of practices are there which we can still work, and how it can be.
I think the learning is going very well. I was very happy to see the partnership between the faculty and the fellows and the trainees. This is so critical, you know, for us, all of you, to be mentors to these young people, to really cultivate their interest, to guide them, encourage them, you know, rather than being very didactic or stentorian and, you know, you don't know this, you don't know that. I like the tone change. I like the pairing up of an attending with a resident. All of these things are very, I think, inspiring to me. I mean, you know, the amount of attention that you're giving to each discipline is seen. I think if I was talking to the residents today, I would tell them that let's try not to be too much about this is what you do. Go, put too many algorithms. You have this you know, you have this curvature, you must do this, you must do that. Because we actually have very poor data to support any of those things. There are broad things that we know that we have experienced. So what I would tell residents is there's a lot of room for good studies. In India, you're gifted with a large volume and an excellent clinical situation where you see such diverse volume and such diverse pathology. Think forward. Think about all of the things that you talked about. And what is actually supported by high levels of evidence is actually a very small amount of information. So construct trials, you know, do some randomized interventions. These are things you can do in India uniquely compared to the rest of the world. And I think you can really contribute. There's a lot of room for you all to contribute to the science of pediatric urology going forward.
Thank you. Paul, you wanted to add something, yeah, please.
Yeah, I totally agree with Asim. I think collaboration is really important. You have got huge institutions with a lot of numbers. You can actually change the field of pediatric urology with your numbers and doing some studies looking at all these fields. There's a lot of unknown in pediatric urology. And I think you guys have an opportunity of really looking at large volumes, doing some studies and looking at some of the questions that we have not answered yet. And I think that's a huge opportunity. I think we've done that with the bladder exophy group, but I think there's a lot of unknowns in pediatric urology that you as a group can help.
Okay, that's Anand Kumar sir. You want to respond? Tell something.
Yeah.
Your observation, sir.
Yeah, this is a very novel approach. Here the students and the mentor and teacher both were competing and both were open to questions, and the mentor is supporting it. Lot of mentors may not like to be sitting in the same position and being questioned for things. So that is one of the things, and I saw that it was a very nice.
And sir, they really enjoyed, sir. That is what the feedback is. That mentors enjoyed after a very long time that they are made the part of these competitions and in the internal department, because there were a couple of 3 teams from the Vellore, same department, 2 teams from NU hospital, 2 teams from the Indore. So they were having a healthy competition between these mentors.
And I saw their spirit. I liked it. So that was one of the concept I liked it. And the same thing is that, see what Ashish is saying, it is very true that we have large number of patients and we need to do the trials. The only thing which I have seen is lacking here is the institutional support and the financial support, and which we need to run it. Number of times we tried and things didn't work out very well because of the infrastructural and financial problem. But things are improving. India is also improving. Our infrastructure is improving. Financials are improving. And I hope now the things are getting better and we may be able to do more and more proper trial, not only in one institution, inter-institutional, and which needs a lot of coordination and cooperation to do that. And we are rather at Urology Society of India, we have started this concept. So we are starting with the one in oncology, then taking up in other subjects to do collecting the data from the various institutions is the first thing. And then second, they're doing the trial on some specific aspect and involving various institutions. so that we get first the national data, as well as that we get the, and we are going to answer the national questions which we have about tuberculosis. Our stricture urethra is very different than what is seen in the West, and so many other. Stone disease is very different. So we are going to answer those questions, but probably it is a long way to go. But we have already started working on it. Process has started, and maybe it will take a pace, and in future it will shape up, and you will see more and more proper trial to answer a specific question will come out from India.
Okay, sir, thank you very much. So before I hand over to the Rajiv, a couple of words from the SS Joshi sir and Venugopal sir before the result is out, sir. So you have worked as Professor Anand Kumar and Rajiv Sood mentioned that because of you, we could save this pediatric urology. Tell your experience, or you can say that how much we have marched on the shoulder of you giants. Venugopal sir.
Sham, let's have that.
Sir.
Can you hear me?
Yes, sir.
Let Sham start.
Let the Shams. Dr. Joshi is there. Joshi sir.
Unmute.
Joshi sir was having some issue with the audio today.
Okay.
A couple of issues. Yeah. So you take.
Can you hear me?
Yes, sir.
I think the whole USA has to be given a much needed compliment as far as organizing this program is concerned. It's a well-organized event, both for the participant, candidate, as well as for the mentor. And it was very, very difficult to differentiate one from the another. Pediatric urology has come a long way. I think when I started having interest in pediatric urology, maybe more than 50 years ago, pediatric urology was in the infant stage. I mean, mostly all over the world and especially in India. Our concepts are so old when compared to what it is today. And if I had to say honestly, what answers I gave to get my MCH examination and got my MCH degree, if any candidate answers like that now, he will fail 100 times. That's advances that has occurred as far as pediatric urology is concerned. More importantly, I think the most important thing is Shyam and myself tried our level best to develop pediatric urology in this country along with a few others, colleagues of ours. But unfortunately, we could not do it full justice, mainly because at that time, you must remember, our main interest was developing urology as a whole, and pediatric urology came only a part of it. So we had our own limitations, but that limitations are overcome now. And I think today, we have got enough and more personnel who are interested in pediatric urology and would like to develop pediatric urology as a subspecialty and maybe for the livelihood as well. I think what Ansari said is a very important point. It is not a question of who should take the lead. Is a pediatric surgeon or a pediatric or a urologist? The most important thing that I always look at it is who got the lead. Ansari said very clearly, and I really reiterated that, if I did not get the lead to do pediatric urology in my center where I was working and develop pediatric urology as a specialty, probably I could not have done much on pediatric urology. But having said that, perseverance and dedication are the two things that is most important in trying to develop any new branch that is coming up. And pediatric urology is not a new branch, it's an old branch, but we are investing or inventing the whole thing in a proper way so that we can get better yield and better people to manage pediatric urology problems in this country. Thank you very much.
Thank you very much, sir. And before I hand over, the last is the Shruti. Shruti, have you joined? Hello, Shruti Pandit. Yeah. So Shruti, Rajiv, Shruti want to say something on behalf of all the resident fraternity to the USI. So let's hear Shruti. Shruti is a very bold girl. She was the only female participant in these 31 teams, and her subject was very tough. But she answered every questions very boldly. And let's hear what is her observation, and she wanted to share the gratitude. Yeah.
So, firstly, I would really be thankful to be given this opportunity to express my gratitude on behalf of all the residents. I think I can say that it's ignited our interest in pediatric urology, which is a relatively less exposed branch in some of the centers. Special thanks to USI and ISU for organizing and giving us an opportunity to participate on these platforms and present in front of the stalwarts of urology. Special thanks to Dr. Anil Takwani, sir. So you have taken great effort in organizing this, and you have contacted each one of us personally, have made sure this program has gone on successfully, smoothly, have managed each and every small glitches as it has come along on the way. And we are very impressed by it, sir. And we're also looking forward to more such sessions organized by USI ISU. We are now there'll be a participation double the number, sir. And we're very thankful, sir. Another particular thanks to Professor P. Venugopal, sir. Despite sir is always available for us for any sort of guidance, for any sort of help we ask for, any input, and sir's inputs are so valuable to us. It really makes a difference, sir. And of course, our HOD, Dr. Arun Chawla, sir, he's always has been a mentor and a guide to all of us, and has always encouraged us to be better, to learn more. And of my guide, Dr. Suyog Shetty. Overall, this has been a wonderful program. We have learned so much presenting, and we have learned so much from the other residents who have presented as well. Everybody has done such a wonderful job. And whether we have won or not, I think I can say this on behalf of all the residents. We have really taken this in good spirit, participated, and we would look forward to doing more of this again, sir. Thank you, sir. And
okay,
congratulations to you, sir, for this wonderful organization.
Thank you very much. So with that, I think Rajiv, you will take care of some couple of the comments from the experts or stalwarts. Now you decide. It is over to you. And thank you again very much for this opportunity. It was a really excellent journey interacting with the mainly with the residents and their mentors, solving their problems and talking to them. How they can improve, how can they work on these videos and audios and all those things. But overall, it was a fantastic journey interacting. I really feel myself much younger in last couple of weeks interacting with the residents. Though not being in the teaching institute, I do not get that opportunity. But this is a very fantastic opportunity given to me by you and the USI Council. So once again, thank you very much. Thank you very much to all participants for wonderful presentations, their mentors, my experts for coming to this virtual platform whenever I demanded you. Similarly, very much thankful to Pramod Reddy, not to only come, but to offer the scholarship which we discussed with him. And once again, very much thanks to Professor Paul and Dr. Asim Sukla to join this meeting in a very short notice, which is really wonderful. And that is also on a working day in the morning. I know that Dr. Paul is having some commitment 8 o'clock onward in his hospital, but still he could keep here till the end. So wonderful that, sir. Thank you very much for that. We have a Sam Joshi there. Joshi sir is there, but it is over to you now, Rajiv. So thank you once again, and over to you.
Thank you, Anil. It was a wonderful program, a very tough fight in the final. And all the five participating team has done exceptionally well. But in a competition, a very small matter matters, because in a tough competition, you first see what is the negativity and erase off the thing, eliminate the competitor to pick and choose the best one. So the results are with me. It is not the result that matters. It is the participation and the way you have participated and the way you have competed that matters a lot. So the second prize goes to Dr. Samarth Kumar Patel and Dr. Siddharth Yadav for their topic, Continuous Antibiotic Prophylaxis in VUR, Current Concepts. They are from VMMC and Safdarjung Hospital, New Delhi. They have been judged second. But I tell you, among all the participants, there is a thin, narrow margin left, because in such a competition, everything has to be looked into, whether somebody fumbles to answer a question, how somebody answers all the questions smoothly. All these have been taken deeply into consideration before giving the judgment. And the first and the winner is Dr. Amit Kumar and Dr. Manoj Kumar Ji from Government Medical College, Trivandrum. It was a fantastic presentation by them. And what mattered is, without any nervousness, the smooth way they answered most of the questions before losing no time. That gives extra advantage marks to them. And their topic was prenatal and postnatal PUJ-like hydronephrosis, investigation protocols and management algorithms.
Rajiv, just sorry to interrupt you, but this is something regarding the Amit Kumar. Amit Kumar wife was pregnant and she was forced for LSCS because of hypertensive crisis. And baby born before 3 days with the LSCS. Wife is still admitted with the hypertension. And in such situation, he prepared this presentation, taking it very positively. So this is just to inform, and much more we can say that he deserves much more than the simple congratulations, because he was passing through the good news that the baby delivered very successfully and doing well, but the wife is still in the hospital for the hypertensive crisis.
Thank you, sir. Thanks a lot, sir. I would like to thank everyone, sir, especially my HOD, my unit chief, Dr. Vasudevan, Dr. Venugopal, Dr. Satish, sir, my mentor, Dr. Manoj, sir. Really thank you for all the support, sir. Without your help, and especially Anil Takwani, sir, guided me in the very last moment, and because of which I had to change a lot of things, and which really helped me reach this stage. Thank you, sir. Thanks a lot.
Thank you. Congratulations.
Amit, congratulations.
Thank you, sir.
And the prizes will be, the first prize from Urological Society of India will be a check of rupees 10,000 and 2 plaques for the faculty mentor and the resident companion. And the second prize will be 5,000 rupees and plate for the participants. And in addition, the mentor, Manoj Kumar Ji, will be nominated by USI to the Pulli Pradeep Reddy Trust, that is the Cincinnati Children's Center, for the 1-month scholarship to spend time in the Department of Pediatric Urology under Dr. Pratap Reddy, and following which attending the AUA spring meeting, which all will be borne by the Pulli Pratap Reddy Trust, all inclusive.
Can I say a few words?
Yeah, go ahead.
Sir, actually, thank you everyone for giving such a nice platform to present in front of the stalwarts of urology, especially pediatric urology. And once more, thank you for involving us teachers also in such a program, so that we can also actively participate and we can also refresh our knowledge, and we can get more knowledge from pioneers of the pediatric urology. Thank you, sir. Thank you for giving such a platform. Thank you.
This is an initiative so that once you come back from Cincinnati, you will meet more younger generation trainees into the field of pediatric urology, so that the pediatric urology can flourish, subspecialty can flourish. This is the main aim. You come back here, you meet more youngsters into the field of pediatric urology. That is the basic aim of sending you to Cincinnati and spend a good period of time there under Dr. Pratap Reddy.
Yeah, one thing I would like to say, that I am very happy to see Amit did so well, and actually he worked with me before he went for this MCH urology program. So I'm very happy to see that he evolved so well. Thank you.
Thank you, sir. Thank you. Really blessed, sir. Thank you, sir.
I would like to thank Asim for spending the weekday morning, whole morning with us, as well as most of all, also spending the whole time with us, is around 3.5 hours with us. Thank you all once again. Thank you, Anil, on behalf of USI and ISU. We have done a wonderful work in a short period of time, planning, executing, and till the last moment, we were into this, till this morning even.
It won't be possible without your support and your guidance. So once again, I thank you very much for the support, guidance, and the
We
opportunity.
have been corresponding to AUA and here even till late last night.
Yeah.
Get this thing through.
Yeah. So Pramod was very keen that it should be out as early as possible. So it will add the excitement into the competition as well as the excitement to the mentors, those who are working hard for the students. So that is the reason that we work very exhaustively for last 2 days. Yeah.
Dr. Rajiv, members of the pediatric urology subspecialty session for working as a team to make this program a grand success. And again, many more things are in the pipeline, which will come in the days to come.
Dr. Rajiv, I want to mention only one thing. 2 decades back, when we were discussing pediatric urology, and after the experiment of one of the conference in the West on pediatric urology, everybody was thinking that it is very difficult to organize conferences and to do justice with the specialty of pediatric urology. In India, gradually we have grown, and with the guidance of Dr. P. Venugopal, Malkarjun Reddy, Ansari, and the likes of that, this has Dr. Sham Joshi in the beginning, we have come a long way, and the new normal which has come to USI in the COVID times, or maybe the e-academics which have been introduced. Now, this pediatric urology is giving shape to the entire urology programs. This is a great coordination of our dynamic secretary, Dr. Anil Takwani, and all the experts who have participated, and more than that, the residents who have been introduced into this system. All the residents, there is a new enthusiasm to join pediatric urology, and it will go a long way, as Dr. Rajiv has mentioned, that now after this, the more coordination with AUA, more coordination, Ashim Shukla is there, Dr. Paul is there, and they are the assets for this kind of program. And this we are going to nurture all this culture which we have now able to live in further. And we are very happy that we were able to coordinate and to have the participation of international faculty of that caliber. And we have myself and Dr. Rajiv TP has visited Dr. Ashim Shukla just before this pandemic, and we remember the way the things are working there for pediatric urology. And I think India is not going to be far behind. And with your support, our AUA partners, with this support, it is going to be great future for our collaboration and cooperation and AUA USI friendship. New rewards have come to support all this effort, and we see that everybody is happy at the end. The winners are happy with the concept of mentors, the faculty which we are able to create. Not only the residents involved, but the faculty also is groomed with this kind of program, and this will give lesson to other subspecialties of USI and the cell-based USI functioning. Thank you.
Thank you very much, Rajiv. Just one little clarification. I could not incorporate Dr. Hemant Pathak to ask the question. The reason is that there was a team from your institute, so I spared you. But you are always a big backbone for me. You have always pushed me forward, and you given me ample of opportunity to reach to this level. So thank you very much to you, sir. But the reason is that not to incorporate that your team was talking on the hypospedia, sir. Raju.
Now I would request Dr. Arun Chawla to offer the vote of thanks. Over to you, Arun.
Okay. Thank you, sir. Thank you. I think today is something like a special day when academic this gala event of pediatric urology subsection is coming to its conclusion. An interzonal program and grand finale today, a program so well planned, scripted so well with all the subjects pertaining to pediatric urology, executed to perfection, and very well appreciated and applauded by all, is coming to a logical conclusion. Congratulations to Dr. Anil, Dr. Rahul, and your team, as well as Dr. Rajiv TP, for backing this team and giving them guidance and vision and making them task easier. Congratulations to Dr. Anand Kumar, President USI, and Dr. Rajiv Sood, Chairman USI ISU, for having a pragmatic approach to adopt new ideas. I think you have given a very memorable and enjoyable program. Thanks to all the experts from India as well as the international experts. Today you have seen Dr. Aseem Shukla staying all the way to the whole proceedings. Dr. Paul also, he just left just now, and thanking in the chat section and sharing experience, how enjoyed the program. Thanks to all the experts with their valuable inputs, the program has reached to higher heights with every day passing and to this grand finale. As a secretary of Association of Southern Urology, I feel so proud that one of our team has been awarded as the winner in the and has finished the podium finish. So thank you everybody for putting up a very nice a program, and I think this is making us as a members of USI very proud. On a personal front, I think it was a learning experience as you see all the facets of pediatric urology being covered. I think not only me, the way responses are coming, everybody has enjoyed this total learning experience in pediatric urology. Thanks one and all, and congratulations to everybody.
Thank you, Arun. And I would like in the end to thank IPCA, the support team from IPCA, for all the logistic help they have offered to the USI, and also the team, central office team from USI, who are the backbone for all these programs.
Let me join Raju to appreciate the effort of the IPCA. They were outright with us whenever we called the Zoom meeting for the trial runs and this and that. They were always there. They were updating about the registration process, providing the links, as well as the giving us count. Today we have almost touched the 1,000, or you can say that exact figure is around 900. So I am really, I just missed that, but I am really thankful to the IPCA team and the support system, technical systems. Yeah.
Thank you all once again.
Thank you.
Have a good day.
Stay safe, stay well, stay
Shall
healthy.
I stop
Bye.
our live stream?
Bye. Thank you very much to join.
Shall I stop our